Dr. the Honorable Christopher Tufton, MP, Minister of Health and Wellness. Mr. Ian Stein, Pan American Health Organization, World Health Organization representative for Jamaica, Bermuda, and the Cayman Islands. Dr. Emily Kanye Dokubo, Captain, United States Public Health Service, the CDC Director, Jamaica and the Caribbean Regional Program for the U.S. Centers for Disease Control and Prevention. Dr. Joy St. John, Executive Director, Caribbean Public Health Agency. Dr. Wayne Henry, CD, JP, Chairman and Director General for the Planning Institute of Jamaica, and Professor Marvin Reed, Chairman of the Essential National Health Research Committee. Other specially invited guests, presenters, members of the media, ladies and gentlemen, those present and those joining us online, good morning and welcome to the 13th staging of the National Health Research Conference. It's lucky 13. This year is being staged and observed under the theme, Combating Non-Communicable Diseases, Looking to a Healthier Future. What an amazing statement and declaration we're making this morning. Combating, we're taking it on. And it's a fight we are going to win when we look to a healthier future. The theme comes at a time where countries, regionally and globally, are raising awareness and implementing strategies to combat NCDs. So the National Health Research Conference is an event where researchers submit their health-related abstracts, presenters share their wealth of knowledge among us based on the hard work that they have done. Their findings will absolutely impact public health positively and will benefit us as a people. So I'm sure that most of us are looking forward to an insightful and engaging session over the next 3 days, starting today and ending on Friday. I want to thank Ms. Paulette Bellamy, Ms. Rosalind Williams, and Mr. Alex Martin Blanken, Touch of Elegance, for that great start to this morning's session. Thank you so much for that prelude. And now I invite everyone to stand for the playing of Jamaica's national anthem. Please remain standing. One of the most beautiful prayers that we all say as Jamaicans, our national anthem, about this land that we love. But now I invite Mr. Keith Foga, Director, Health Promotion and Education from the Ministry of Health and Wellness, to deliver the invocation.
Good morning. Let us pray. Heavenly Father, we pause now to say thank you. Lord, we're not guaranteed that we would be here this morning, yet here we are, and how grateful we are. Those here present and those online, we thank you, Father. Lord, we thank you for the opportunity we have to be here on this 13th conference. Lord, you know the journey has not been easy, but Father, you have empowered persons, Lord God, to be able to come together, plan and put together this conference. And we give you thanks for the obstacles you allowed them to overcome, for just enduring, Lord God, and for hosting what we know is going to be a great conference. We thank you for every presenter, Lord, every researcher. We thank you for the body of findings that we will have, Lord, information, Lord God, that we can use to influence, to shape, to develop programs and initiatives that will help to improve the health of our nation as we indeed look to a healthier future. So, Father, we pray your blessings upon everyone here. We thank you for our Honorable Minister, for our Chief Medical Officer, for our Permanent Secretary, for those leading, directing our Ministry of Health and Wellness. Lord, you know the challenges that come, but God, we pray that you continue to give them wisdom to strengthen them. We thank you for the partners we have who help to make events like this a reality, who help, Lord God, with our overall health system. Lord, we pray that at the end, not just of today, but these 3 days, we all will leave feeling empowered and just grateful for the opportunity to be here. So, Lord, we just pray over all the technical issues, Lord God. We pray against any glitches right now. We just pray that everything will run smoothly as you would have it planned. We give you thanks and praise in Jesus' name. Amen.
Thank you very much, Takis, and you may be seated. I'm excited about the next 3 days. Who is excited? I think so. Research is such an amazing thing, and I know that some of the things that we're going to be sharing in these presentations and seminars and panel discussions will be groundbreaking, inspirational, as we continue to combat NCDs. To deliver the official welcome, ladies and gentlemen, and please put your hands together so she also feels welcome, we invite Dr. Karen Webster-Carr, Chief Medical Officer at the Ministry of Health and Wellness. Let's hear it for her.
Ms. Delia Harris, Masters of Ceremonies, Dr. the Honorable Christopher Tufton, MP, Minister of Health and Wellness, Mr. Ian Stein, who is online, Pan American Health Organization, World Health Organization Representative, PWR, Jamaica, Bermuda, and the Cayman Islands, Dr. Emily Kiney, Captain, United States Public Health Service, CDC Director, Jamaica and Caribbean Regional Program, U.S. Centers for Disease Control and Prevention, Dr. Joy St. John, Executive Director, Caribbean Public Health Agency, Dr. Wayne Henry, CDJP, Chairman and Director, General Planning Institute of Jamaica, Professor Marvin Reed, Chairman, Essential National Health Research Committee, other specially invited guests, presenters, members of the media, ladies and gentlemen all, good morning. It is with great pleasure that I welcome everyone to the 13th staging of the National Health Research Conference. It has been 13 years of bringing to the people of Jamaica and our region public health insights through research. I anticipate that this year's abstracts and other presentations will build on that legacy as we engage on the varied offerings through the lens of this year's theme, Combating Non-Communicable Diseases, Looking to a Healthier Future. I take the opportunity to commend the researchers who have invested time and other resources to prepare and submit their work, and on a range of topics including nutrition, NCDs, maternal and child health, health economics, and ethics in research. To the National Health Research Conference Secretariat and others who have contributed in whatever way to making this year's event a reality, you have my thanks, many, many thanks. I encourage all of us here, those in the room as well as those online, to make the best use of this year's conference. Be edified by the research offerings, ask questions, talk among yourselves, engage, and network. In this way, we all make a contribution to public health, collaborating to inform or otherwise influence policy and program planning, and the research that drives them. Research, ladies and gentlemen, does its job when it's insightful, and it gets to be that way by first being interrogated and then engaged with. Once again, a very warm welcome to all. Now let's have a wonderful 3 days. Thank you.
Thank you very much, Doc. Insightful and interrogative. That's what you said. And that's what we're looking forward to over the next 3 days. We can't do this without support of our partners and our stakeholders. And so now we're going to have some greetings from some very important people who are going to help us in this fight against non-communicable diseases. And we're going to start first on Zoom. Dr. Joy St. John joins us, Executive Director from the Caribbean Public Health Agency, CARPA. Dr. St. John.
Thank you, Madam Master of Ceremonies. Dr. the Honorable Christopher Tufton, Minister of Health of Jamaica. Mr. Ian Stein, PWR of PAHO. Dr. Emily Kaine-Dokupo, United States Centers for Disease Control Caribbean Regional Office Head. Dr. Wayne Henry, Planning Institute of Jamaica. Dr. Karen Webster Carr, Chief Medical Officer. Dr. Andreen Grant, Director for Epidemiological Research and Data Analysis, other directors and branch heads from the Ministry of Health and Wellness, and Professor Reed, participants, members of the media, ladies and gentlemen. Good morning, and thank you for your kind invitation once again to speak on behalf of CARPA at this Jamaica National Health Research Conference. Jamaica has had a rich history of high-quality research in NCDs, which has benefited the Caribbean region. Despite this rich history, I am very glad that this conference is showcasing NCDs, not only because it is critical to build individual capacity for research, but even more so because evidence-based decision-making to inform capacity building actions and to monitor policies that have been implemented is required to ensure non-health sectors are truly supportive of health interventions to stem the tide of NCDs. This conference is an important step towards achieving this. In CARICOM, there's a need for more data on the burden of NCDs and their risk factors. We rely too heavily on global data or data from the region of the Americas. We know that the rest of the region of the Americas is vastly different from CARICOM. Its population size, lifestyle, culture, health promotion, and services infrastructure. There remains a lack of current data on NCDs, especially since the COVID-19 pandemic. And so, more research is required to understand the Caribbean context, the drivers of the epidemic, and how the long and short-term impacts will affect the health status of Caribbean residents throughout the life cycle. In this regard, there is a need for more operational research and the use of implementation science to identify what works and what is required to bring best practices to scale in the Caribbean context. This is especially important as we seek to manage the ways in which COVID-19 has worsened the NCD situation. NCDs cost us a lot. The hidden costs far outweigh the direct costs for treating these diseases, but the direct costs are huge. A recent study by the World Obesity Federation in 2022 reported that the economic costs of overweight and obesity projection in 2060 in Trinidad and Tobago will account for 10.2% of GDP, or $4.9 billion. And in Jamaica, will account for 5.85% of GDP, or $1.5 billion. In the context of NCD's prevention and control, the success of programs is very much impacted by actions in non-health sectors. I think of trade, manufacturing, media, and education, to name a few. Much of the change to be undertaken will require the promulgation or enactment and enforcement of legislation. So different indicators are required for different and unusual actors, and the use of legal epidemiology and policy surveillance will become more central to the monitoring and evaluation of governmental and private sector interventions and corporate responsibility, respectively. I hope this conference goes a long way in unpacking these new paradigms for the young and the experienced researcher. This is new territory, which the Caribbean must explore thoroughly and report on extensively. Jamaica remains the source of innovation for which it has long been famous. Just in September, CARFA launched Caribbean Moves, which was patterned after your very own Jamaica Moves. This is one of the many practical but fun initiatives throughout the region that will help to combat some of the risk factors for NCDs. So let's get moving and let's keep moving. I applaud the Ministry of Health and Wellness for having an essential health research committee, as well as a national research agenda. And I'm also pleased that CARFA is a member of that committee, represented by our Head of Medicine's Quality Control and Surveillance Department, Ms. Nicole Ennis. I wish you, the organizers and the participants, the best for this conference, and I am anxiously awaiting the research that will be presented. NCDs, unfortunately, because of how badly they affect the young and the old, remain the Caribbean's business. And we must do all that we can to better our lives and the lives of future generations. Congratulations to the planning teams for hosting yet another research conference. I thank you. Over to you, Madam Master of Ceremonies.
Thank you very much, Dr. St. John. Wow, what a great presentation. Talking about the needs, you heard the charge, implementation cycles, scaling best practices, looking at operational research. Did you hear the figures? The economics of NCDs is real. And so it's important what we're doing over the next 3 days. It's not just about making sure Jamaica is physically healthy, but financially healthy as well. And the source of innovation, Jamaica, that's what she says we are. And I'm sure over the next 3 days, we'll find some additional innovative ways to combat NCDs. Thank you again, Dr. St. John. And now we will hear from Mr. Ian Stein, Pan American Health Organization, World Health Organization representative for Jamaica, Bermuda, and the Cayman Islands.
Dr. the Honorable Christopher Tufton, the Minister of Health and Wellness, Dr. Emily Kaine, the Caribbean Regional Office Director for the United States Centers for Disease Control and Prevention, Dr. Wayne Henry, the Director General of Planning at the Institute of Jamaica, Dr. Jacqueline Besseser-McKenzie, the Chief Medical Officer of Health in the Ministry of Health and Wellness, Dr. Webster Carr, the National Epidemiologist at the Ministry of Health and Wellness, Dr. Adrian Grant, Director of Epidemiological Research and Data Analysis, Directors and branch heads from the Ministry of Health and Wellness, ladies and gentlemen, good morning. Allow me to begin by congratulating the Ministry of Health and Wellness on the staging of this, its annual National Health Research Conference under the theme of combating non-communicable diseases, looking toward a healthier future. The longevity of this conference, now its 13th session, is a confirmation of its relevance and importance for advancing research in health and the significant contribution of researchers from Jamaica to advancing knowledge to the Caribbean and to the world. It's an unfortunate challenge and a well-established fact that NCDs are a major driver of morbidity and mortality in Jamaica, and additionally, they pose a significant burden on the national economy. As such, we look forward to these discussions' contribution to overcoming some of these challenges. In this context, the Pan American Health Organization and the World Health Organization partnered with the Ministry of Health and Wellness of Jamaica, the United Nations Development Program, and RTI International a few years ago to develop an investment case for addressing NCDs. Unsurprisingly, these results indicated that investing in the prevention and control of NCDs would support the government of Jamaica to avoid significant direct costs and substantial indirect economic losses. The investment case noted that over the period 2017 to 2032, scaling up the recommended package of interventions would save close to 6,000 lives and restore over 67,000 healthy life years. It would also avoid labor productivity losses of over 47 billion Jamaican dollars and save over 30 billion Jamaican dollars of direct medical costs. And lastly, it would substantially grow the gross domestic product as early as year 5 of this investment. It is well documented that the COVID-19 pandemic increased challenges in the prevention and control of NCDs. Unfortunately, many people who require and required treatment for diseases such as cancer, cardiovascular diseases, and diabetes have not been able to receive the health services and medicines they need. The pandemic demonstrated that it is vital that countries find the necessary ways and ensure that essential services for NCD treatment and care continue no matter the context the health systems face. The pandemic also highlighted the key role of research and how it plays an important role to the current public health challenges. Since the pandemic, we've seen how research allowed us to pivot and improve our response to COVID-19, and it presents similar opportunities for dealing with NCDs. By harnessing the power of science and research at the heart of health systems, we can achieve 3 goals: better health, better protection from epidemics and pandemics, and better coverage of people. Ladies and gentlemen, it is crucial to protect the most at-risk populations, recognizing that the impact of the pandemic has been particularly severe for the most vulnerable and has worsened socioeconomic divides. Now is the time to expand the scope of health research, and we need to expand collaborations with researchers and international partners. Furthermore, integrating research with equity ensures we improve people's health and lives without leaving persons behind. Allow me to acknowledge the critical role of the national institutions and research centers in Jamaica that provide critical support in advancing knowledge to improve the health and lives of the Jamaican people and, by extension, the world. We at PAHO are committed to advancing capacity building on knowledge translation to ensure the scientific research is translated in evidence-informed policies, as well as promoting the integration of the Ministry of Health and Wellness and researchers into global research networks. In this context, PAHO provided support to the Ministry of Health and Wellness's efforts to develop a national policy on research for health, and we look forward to strengthening this collaboration. I wish you a fruitful and productive discussion over these days, and I look forward to strengthening our important collaboration. Have a good morning.
Thank you very much, Dr. Stein, for bringing us those greetings. And now we're going to hear from the CDC Director, Jamaican Caribbean Regional Program for the U.S. Centers for Disease Control and Prevention. She's also captain of the United States Public Health Service, and we're glad to have her with us here in person, Dr. Emily Kane DeCupo. Please make her feel welcome. Honorable Minister, Dr. Christopher Tofton, Jamaica Ministry of Health and Wellness, Dr. Karen Webster Carr, Acting Chief Medical Officer, Mr. Ian Steen, representative of the Pan American Health Organization, Dr. Joyce St. John, Executive Director of Caribbean Public Health Agency, Dr. Wayne Henry, Chairman and Director General of the Planning Institutes of Jamaica, Dr. Adrian Grant, Director for Epidemiological Research and Data Analysis, directors and officials of the Ministry of Health and Wellness, distinguished guests and colleagues here in person and virtually. It is with great pleasure that I represent the United States Department of Health and Human Services, Centers for Disease Control and Prevention, at the 13th Annual National Health Research Conference focused on combating non-communicable diseases, looking to a healthier future. Health is one of the top priorities for U.S. foreign assistance here in Jamaica and the Caribbean region. And as CDC celebrates 75 years of public health service, our work has focused on issues of global health concern, working to improve the health, safety, and security of populations globally. With offices in over 60 countries across the world, including here in Jamaica, CDC collaborates with ministries of health and with partners to enhance global health and to reduce the premature non-communicable diseases, deaths, and disabilities. The United States, through the Centers for Disease Control and Prevention, provides public health expertise and strategic support to the governments of Jamaica and partners to ensure that we are strengthening the public health system, achieving sustained HIV epidemic control, and increasing health security capacity to prevent, detect, and effectively respond to health threats. Through our longstanding partnership, CDC's Caribbean Regional Program here in Jamaica works in close collaboration with the Ministry of Health and Wellness to strengthen surveillance, laboratory systems, health workforce, and emergency response capacity in the country. Together, we have made major achievements. Over the past 3 years, the COVID-19 pandemic has brought public health to the forefront of the world's attention and underscored the importance of resilient health systems to ensure continued service delivery. The pandemic also showed us the importance and value of nations working together to ensure global health security. Non-communicable diseases such as heart disease, cancer, chronic respiratory disease, and diabetes are the leading causes of morbidity and mortality worldwide and represents an emerging health threat. Deaths from NCDs exceed the sum of all communicable diseases worldwide and also account for over 7 out of every 10 deaths globally, with 85% of premature NCD deaths occurring in low and middle income countries. Here in Jamaica, NCDs account for the leading causes of disability and death, taking a huge toll on the health of its citizens and the economy of the country. NCDs also play a key role in outbreak preparedness and global health security. Over the course of the pandemic, evidence has shown us that NCDs and their risk factors increase the likelihood of hospitalization or death from COVID-19 across all age groups. Addressing NCDs enhances global economic and health security as countries with healthier populations are more stable, prosperous, and better able to avoid health crises. In collaboration with partners, CDC works to reduce the impact of NCDs with activities focusing on promoting and supporting innovative, evidence-based interventions to prevent and control non-communicable diseases. We produce scientific evidence on NCDs, risk factors, and interventions to develop effective programs and enable informed decision-making. And to increase NCD capacity globally and increase skills in surveillance, prevention, and control,
CDC strengthens public health infrastructure and workforce capacity to empower countries to address health needs and avoid health crises. We improve NCD surveillance, monitoring, and evaluation systems to enable countries set their own priorities, target interventions, and monitor success. Our efforts are aligned with global targets, including the UN Sustainable Development Goals and the World Health Organization's Global Monitoring Framework. Now, the success of U.S. investments in global health through programs such as the President's Emergency Plan for AIDS Relief, PEPFAR, have demonstrated the potential for public health improvements in low and middle income countries. As health needs continue to evolve, existing platforms for specialized disease-specific care can serve as catalysts for broader health services. For example, systems put in place through PEPFAR infrastructure for HIV care have facilitated the delivery of hypertension control and cervical cancer prevention services in some countries. On a broader scale, coupling services for communicable and non-communicable diseases help to maintain investments in health systems between and during outbreaks, ensuring a more consistent source of health funding. This is a strategic and a sustainable investment in the long-term capacity of countries to address local and global health threats. CDC is a committed partner of Jamaica Ministry of Health and Wellness and supports its efforts to improve health outcomes in the country as outlined in the National Strategic Plan. We applaud the ministry's prioritization of NCDs and implementation of initiatives like the Jamaica Moves campaign to improve the health of the population. This conference provides an opportunity for further collaboration between Jamaica Ministry of Health and Wellness and partners to address health priorities, integrate NCDs in global health security approaches, and increase health equity. Minister Tofton, we commend the Ministry of Health and Wellness and acknowledge the efforts of all health workers and partners in addressing health issues. On behalf of the U.S. Centers for Disease Control and Prevention, I wish you a successful conference. We look forward to continued partnership to improve health outcomes, to foster healthy populations here in Jamaica, the Caribbean region, and globally. Thank you.
Thank you very much, Dr. Kanye. And so we now have our final greeting this morning, and it will come to us from the Planning Institute of Jamaica, Chairman and Director General, Dr. Wayne Henry.
Ms. Delia Harris, Master of Ceremonies, Dr. Jacqueline Bisesa McKenzie, Chief Medical Officer in the Ministry of Health and Wellness, Dr. Joy St. John, Executive Director of CARFA, Mr. Ian Stein, the PAHO WHO Representative for Jamaica, Bermuda, and the Cayman Islands, Dr. Emily Kine de Kubo, the CDC Director in charge of Jamaica, and Ms. Foga, the Director of Health Promotion and Education in the Ministry of Health and Wellness, other distinguished guests, ladies and gentlemen, good morning. It is my distinct pleasure to bring greetings on behalf of the Planning Institute of Jamaica, the PIOJ, at this year's staging of the National Health Research Conference. The conference seeks to bring to the fore the conversations that need to be had around the various health and wellness challenges impacting the country, while seeking to find tangible long-term policy solutions for these issues. The theme for this year's conference, Combating Non-Communicable Diseases, Looking to a Healthier Future, attests to the recognition that non-communicable diseases, NCDs, represent a global and national burden. In 2018, NCDs account for a significant portion of all deaths recorded in Jamaica, and evidence suggests that hypertension, cardiovascular disease, diabetes, and cancers are the four most diagnosed and treated conditions among the Jamaican population. This has led to the dedication of 15% of the health budget to combat this issue. Although morbidity and mortality from non-communicable diseases mainly occur in adulthood, exposure to the risk factors begin early in life. Many of the interventions to tackle the major risk factors for NCDs lie outside of the traditional health sector and require a multi-sectoral approach that includes a whole of government and whole of society response. NCDs constitute a major health challenge that have the potential to undermine the social and economic development of Jamaica. Urgent action is therefore required to mitigate their impact. In keeping with National Outcome 1 of Vision 2030 Jamaica, the National Development Plan, a healthy and stable population can only be achieved when quality health care is accessible to all and health services are provided in an efficient, responsive, and equitable way. The PIOJ supports the Ministry of Health and Wellness in its efforts to combat this threat through facilitating funding and technical assistance from our international development partners to implement the health system strengthening for the prevention and care management of non-communicable diseases program. This program is indicative of a new approach to public health and emphasizes resilience building and responsiveness to new and emerging health challenges. The intended outcome of the program is to improve the health status of the Jamaican population through the strengthening of policies for the prevention of NCDs, and that Jamaica's response to the NCD epidemic is robust and efficient. Beyond this, the PIOJ also continues to provide policy advice and technical expertise through its membership on the National Committee on NCDs and its technical subcommittees, where strategic input is provided on matters related to the prevention and control of NCDs in Jamaica. These mechanisms aid in strengthening the framework for reducing the burden of NCDs in Jamaica. The PIOJ congratulates the Ministry of Health and Wellness on hosting such an important annual research event, where knowledge is exchanged, ideas formulated, and partnerships forged to address issues related to the health and well-being of our nation. It is my hope that the information shared over the next few days will lead to the formulation of policies and programs that support and facilitate a healthier future for Jamaicans. I use this opportunity to remind us that as a nation, we have a duty to future generations and ourselves. Let us all work together and make a difference as we aim to make Jamaica the place of choice to live, work, raise families, and do business.
Thank you very much, Dr. Henry, placing this conference in a critical part of Vision 2030. Can't achieve that without what we're doing here today. And thank you to all our presenters for bringing us those greetings. We're going to change the pace a bit this morning, and we're going to bring you some entertainment. Mr. Brandon Christie is the Geographic Information Systems Officer at the Ministry of Health and Wellness, but he's also a very talented performer. So, bringing us NC Didn't, got it? NCD, right? Let's welcome Brandon Christie.
Hello, good morning. A special good morning to our Minister of Health, Dr. Christopher Tufton, representatives from CMO, PAHO, CARFA, CDC, our branch head, Dr. Karen Webster Kerr, and to our guests joining us online. Good morning, everyone, except NCDs. The piece being presented to you arrives with the aim to educate, highlight, rejuvenate, address the pressing matter of our nation being more health conscious in all areas of our well-being. Ladies and gentlemen, without further ado, NC Didn't. Have we truly forgotten our name? Out of many, but our blood is the same. Our lifestyles may not align, for our habits are what pave our days. A healthy life is definitely the aim. So why are we giving in to mistakes that only medication can tame? Control and prevention is the name. How we initiate it is the game. Physical health is for the body, as mental health is plugged to the brain. NCDs aren't new to fame. They've taken a toll on everyone. Age could never stand in its way. So look within right now and tell me if you are living the healthy way. So why now the silence? Our kids don't need to grow up mindless. Expressing ourselves correctly, that's one way to reducing interpersonal violence. But we sit still while hypertension builds, avoiding accountability for the alcohol we spill. Maybe that's how you ponder to pay the bills, but a life with no balance is like pouring your life down a sink. Get up from your sulking, take a walk or do some gardening. Our land of food and water here is rich. Vision 2030, Jamaica, I know we can do it. Not just to hit a target, but to create a lifestyle that ensures better quality life. A lifestyle that ensures better quality life as well as Jamaica moving. For we need to correct the mind so the body will follow over time. How can we prevent this? How can we better this? So many questions we'll have to answer. But a stroke is no laughing matter. Diabetes, it will have you feeling improper. Uproot what we now know, accept that harmony is needed in order to grow. So gentle folks, do not only yourself a favor, but for the generations to come. For I see a Jamaica where NCD see our people and run. Thank you.
Do you see that, Jamaica, where NCD see our people and run? No, man. True. Answer me. You see that, Jamaica? I think so. You know, when Jamaica moves, NCD have to move out of the way, right? We're going to keep the entertainment going because right now I welcome singer-songwriter Sabre. Let's hear it for Sabre.
Good morning. You're broken down and tired of living life on a merry-go-round, and you can find the fighter, but I see it in you, so we gon' walk it out and move mountains. We gon' walk it out and move mountains. And I'll rise up, I'll rise like the day. I'll rise up, I'll rise unafraid. I'll rise up, and I'll do it 1,000 times again. I'll rise up, high like the waves. I'll rise up, in spite of the ache. I'll rise up, and I'll do it 1,000 times again. For you, for you, for you. When the silence isn't quiet and it feels like it's getting hard to breathe, and I know you feel like dying, but I promise we'll take the world to its feet and move mountains, bring it to its feet and move mountains. And I'll rise up, I'll rise like the day. I'll rise up, I'll rise unafraid. I'll rise up, and I'll do it 1,000 times again. For you, for you, spite of the ache, I will rise and I'll do it 1,000 times again. See, we'll rise up high like the waves. We'll rise up in spite of the ache. We'll rise and we'll do it 1,000 times again. For you and you. Thank you.
Can you help me to say, wow? That was absolutely beautiful. Can you give her another round of applause to me, please? I rise up. That's important. You know, when you're going into battle, it's important to know who you have as your general, you know. Yes, you need someone that's going to think creatively, out of the box, not be afraid to take risks, who embraces innovation and looks at ways, different ways that we can win this fight. And so I call him Mr. Moves, but he is the Honorable Minister of Health and Wellness. To deliver the feature address, ladies and gentlemen, please put your hands together for Dr. the Honorable Christopher Tufton.
Thank you very much, Madam Chair, and thank you very much for that lovely rendition. There's a time in our lives when we all need to rise up, right? And I think research supports that. All right, so I think the main presentations have already been done because our distinguished partners and the CMO acting have really presented a case for research. So I want to take the opportunity to thank them, Mr. Ian Stein, Dr. Dokubo from the CDC, Dr. St. John from CARFA, Wayne Henry from the Planning Institute, and of course to the ministry's team led by the acting CMO, our chief epidemiologist. And to you all who are here and those who are online, good morning to you. Good morning to you. We have coffee in the back for those who want to sleep, okay? All right, so today is my constituency day, but I wanted to be here. I'm going to speak and run. And I wanted to be here because I am a student of research. I am a policy maker grounded in research. I live my life not just on anecdotes, but on what the data suggests. Because I do believe that ultimately, the truth is going to be borne out as opposed to fantasy by what the methodology and the research supports. And in public health, we are dealing with lives. And so it is even that more important for us to recognize the importance of research and to place time and effort in doing so. The context is set, I think, for the next 3 days based on the speeches that I've heard. We all know about NCDs. We know these are lifestyle ailments. We know they claim most of us eventually. We know that there is significant cost, pain, and suffering associated with these lifestyle-related diseases. And we know what we need to do if we want to reduce and indeed prevent these kinds of ailments, certainly in terms of premature illness. Sorry. The big challenge is, why are we not doing it? Have you ever thought about that? Everybody knows that if they smoke, it will ultimately kill them. I don't think there's one smoker who is unaware of that. And we all know in this room that if we drink too much alcohol, there is an ultimate result, or too much salt, too much sugar, too much fat. It combines will end up placing us in a state of paralysis and certainly facilitate our demise, and that we will eventually end up in a hospital. So the theme about combating non-communicable diseases, looking to a healthier future, has grounded in it the need for change. Change at several levels. Change ultimately in the lifestyle of the people that we are here to provide leadership for, but change perhaps also in the approach that we take in how we conduct research, the kind of research that we do, and what happens after the research is concluded. And I am not going to repeat what was already said because I think it is sufficient. And indeed, I think to some extent we are preaching to the choir here. But I want to just mention a few things that I think are going to be important and encourage you as you embark on defining your research agenda, you give some consideration to the change that needs to take place. Not just the quality of the research or the fact that the research is done, but how is the research used as an instrument of change? Because that really is our significant challenge as a people, as a country, and indeed, I dare say, as a world. So firstly, I think we have to make sure that we have applied research. If the research is only going to win the top awards from academic journals and academic committee review, peer review, and find no place in the day-to-day living of our people where it has a positive impact on change, then you have to start asking yourself, is it really worth it? Yes, you may get the accolades from it, but how much impact does it have on the ground in the community? How does it change the lifestyle of an individual? How does it change the habits, the health-seeking habits of our young people in schools around nutrition policy? How does it influence them desiring water as opposed to sugary drink? Or the man or lady who must get a annual checkup but just don't do it until they're sick. How does that influence and impact the research that is? So the application of the research must be a fundamental part of your research design. And to the extent that it can be applied in terms of the recommendations, of course supported by the soundness of methodology, is the extent to which that research is far more valuable around this future healthier living that we have captured as part of the theme. The second is the behavioral component of the research. I know I sound like a stuck record, but I've said, and I keep saying, and maybe some may think I'm biased because I'm a social scientist, I'm not a medical scientist, a clinician, that public health is going to be driven in the future more by the social sciences than by the clinical science. Because fortunately for us, we have exhausted to a large extent the clinical determination of what different health profile will result in, how we acquire, how we carry, and how we try to cure. I mean, the technology continues to evolve clearly, but we are far more advanced in that area than we are in trying to influence behavior, which when you think about it, is really the root cause of why we have those clinical challenges in the first place. Simply put, it's really about prevention, and more so about prevention than it is about cure. If you, and all the parameters support that. If you look at the cost around our health profile, the escalating cost, some of it was mentioned here earlier, you'll realize that we will never have enough to support curative measures. We must always strive to. We have a principle of universal access, but we have to deal with the behavioral side. I would like to see a lot more cross-cutting research that combines behavioral sciences with clinical sciences. And to me, that would represent new and interesting sort of forward-thinking approach to the crisis we face in our NCD's profile today. So again, the issues of around community-based work, the trends in getting people to visit their health centers. How do you deal with the mind and the mindset, mental health, and how you deal with coping mechanisms? All of those, to me, are going to be important. The third is to be bold in your research. They say if you do a PhD, you have to add to the body of knowledge to qualify as a doctoral student. Is that what they say? That's what they told me when I was studying. I don't know if I did any such thing, but that's what they told me, right? My committee. And that's important. But I dare say that the research that we must pursue is more about if we are to turn the corner on the NCD crisis, which seems to be getting worse despite our valiant efforts, we're going to have to shake up the status quo and challenge some of the traditional thinking and some of the traditional approaches to the work that we do. That's really the essence of research, but oftentimes we are timid in making bold statements. You know, I am a magnet for controversy because I make statements that many times I'm challenged on. But I think one of the things it does, it helps people to think, even if they're against my position, it stimulates discussion and debate, and out of that hopefully will come even a more innovative idea. Researchers must seek to be innovative, and you can't be innovative if that innovation doesn't challenge current positions. It's difficult. Otherwise, you become just part of the status quo. And so, you know, we have been struggling, for example, with the role that private sector partners and partners generally play in advancing public health. We have been championing things like frontal package labeling. We've been challenging the elimination of industrialized trans fatty acids. We've been championing the role of advanced nursing practitioners at the community level. We've been looking at how to influence men to see it as their duty to screen for prostate cancer, for example, because, you know, they're afraid of that kind of thing. These may seem like just regular run-of-the-mill challenges, but the fact is our appeal has been very difficult in generating responses to date, and the question is, how do we stimulate using some of the methodology that we have, some new ideas, to get that kind of response that ultimately will improve or support health and wellness. And I challenge you for that, in that regard. The other one is the extent to which research should be followed up as part and parcel of the package by advocacy. Because again, I think that for a very long time we have advocated the right things in terms of the theoretical construct of the research and the conclusions, but we haven't seen ourselves as champions of the cause, which requires a much more visible display around exposing your research, but also challenging those who may think otherwise or who may want the status quo to remain the same. I see my role as minister to advocate And I think researchers need to develop the capacity, or more so of it, or if they have it, to transition to advocating for whatever they have concluded on. Because if you don't, then you are the only believer in that research and the limited numbers who are exposed to it. And one of the reasons why we have these conferences, but I'd like to see more of them, whether they are seminars, discussions around, in the public space, particular sectorial groups, the private sector, otherwise, we must go with our data and we must advocate. One of the reasons why industry normally has an advantage over us when we discuss matters of nutrition, for example, is because they spend a lot more time advocating for why their product and the lifestyle that supports their product is a good thing. It's called marketing. That's my core discipline, so I kind of understand it. And it's all up here. It's about trying to influence perception and drive behavior through perception. I think researchers have to get into that mode too, because you're not going to counter some of the unhealthy habits if you do not be brave and be bold and advocate for health-seeking habits and demonstrating why those health-seeking habits can in fact work. So coming out of some of this work, I would love to see an approach to advocacy and an agenda around advocacy. I think it actually should be an agenda item. How do you take your research from your lab to the streets? We must take the research to the streets. How do you break it down from clinical terminologies to everyday language that the average man can understand? How do you prove your detractors wrong, even when they are bold and they are spending a lot to carry their particular line? These are important questions that I think needs to answer, and perhaps may need themselves to be part of your research agenda. And so I commend that to you. The final point I want to raise is the extent to which research and health research, clinical research, has to make a critical link between the economics of life and why it is in your economic interests, individually and collectively, to pursue health-seeking behavior. I don't think that enough of us fully appreciate the cost of illness. We don't translate. In fact, most Jamaicans, unfortunately, have an expectation that they can live any way they choose, and indeed, those who are advocates of free speech, and so am I, and democracy, and liberal democracy, have a view that people must make their choices, whatever those choices are. And not enough time is spent on the consequences of some of those choices. In the terms of health, there's an expectation that when you're sick, the hospital will always be there. The bed will always be there. The operating theater will always be there. The surgeon will always be there. The medication will always be there. And there, sometimes missing from the conversation is the concept of cost. Who pays for it? And you only need to examine the NHF budget, which I spoke to in my last sectoral, to see how costs are skyrocketing. Generally, but in certain areas, like cancer treatment. If you are unfortunate enough to have a cancer, some form of cancer today, and have to go through chemotherapy and so on, let me tell you, you can wipe out your estate. If you own a house and a car, and you have some insurance in the bank, it can evaporate within a relatively short space of time. Talk to your financial advisor. And if we don't make that correct connection, not to mention the pain and the suffering, the productivity impact, then we're not going to be able to convince the advocates of, freedom of expression and freedom of choice that there has to be some rules of engagement so that those choices can be informed and the consequences can be understood, and hopefully influencing the behavior that we speak of. In that regard, as I have outlined all of these that I think are important, I think the concept of partnership is absolutely critical. And we must search wherever we need to strengthen all of the above, including the advocacy, by seeing ourselves as a part of a whole. Whole meaning the research community. We have embarked on a program, for example, to do joint training with health systems in the US, coming on the heels of COVID, to champion the need for expanded capacity, more training, through shared joint course outlines, sharing technology, where it is more abundant in one jurisdiction than the other, sharing faculty, sharing our own research to compare and contrast notes and methodologies and approaches. And I really do think that the future rests with that. And COVID has shown us, as I said yesterday in the Parliament, COVID was the greatest equalizer of everything, because every one of us was vulnerable. And no matter where you're from, if that isn't enough to pull people together, I don't know what else is. And we do have a tendency, and I'm not throwing any stones now, by the way, to operate in silos when it comes to what we think we're good at, because we're the expert. And I dare say, and I challenge you, that no matter how good you think you are, you could be a lot better through some levels of partnership. I think the ministry has demonstrated a lot of partnerships with PAHO, with CDC, with other universities. As I said, we're now looking at North America for some of that research in particular areas. And I think that is going to help. When I was at one of the health system, Hartford, in Connecticut, and I visited the cancer unit there, and cancer rates are going up in Jamaica. And it's the fastest growing, I'm told. Not the largest segment, but the fastest growing. And they told me there that the area that they serve, mortality rates for cancer is actually coming down. And I was, interested to find out how come. And it's simple. Their methodology have changed because they have found that screening is more successful through direct community intervention. So they have invested heavily in mobile clinics, for example, that go into the community and that makes direct connections with householders, very localized interventions, primary healthcare infrastructure, essentially. But in this case, a mobile primary healthcare infrastructure. I found that to be interesting, and I've bought into that, and we are doing some primary healthcare reform to expand our primary healthcare offerings, expand the team that goes out and visit homes, some of the issues around, what we do to intervene, how we intervene. But I think I raise that to say this is how we can learn from each other and can partner with each other to achieve the core objectives that we're trying to solve. So, I didn't mean to come and give you a lecture here today, but I kind of like lecturing, so I don't mind it now and then, right? I used to do it one time. But I want to commend you for this congregating, because you're bringing like-minded persons together, you're bringing stakeholder partners together, and the cause is worthy. We have established a wellness fund, research fund. I believe the first 50 million is being or should be distributed very soon. COVID has put a dent in why we haven't distributed more. That 50 million comes out of the NHF. And the intention there is to encourage research around areas where we have problems that we need to solve in an applied way. I am hoping that we can put up another 50 million as soon as possible. I would have wanted to see it done annually so that we continue to stimulate the space so that persons are encouraged to do research. And the more you can do it along the principles that I've outlined, or similar principles, I think the more your research will be not just interesting, but will have an impact. It's not just about reach, it's about impact. So I commend the next few days to you, and I wish you all the best. And I am waiting for a few good research papers so that I can help you to advocate. Thank you very much.
Thank you very much, Minister Tufton. You heard the charge from the minister. We're taking it from the lab to the streets. That's how we create a healthy environment. And that's what we're aiming to do over the next 3 days. See what can we bring to the environment that's going to make this change. Minister, I know you have to run, but stay with us a little bit more because we have an unveiling for you to do. But in the meantime, we are going to enjoy a musical performance from Touch of Elegance featuring Paulette Bellamy, Rosalind Williams, and Alex Martin Blanken.
Your fellow man, lend him a helping hand, put a little love in your heart. You see it's getting late, oh please don't hesitate, put a little love in your heart, and the world will be a better place, and the world will be a better place for you and me. You just wait and see. Another day goes by and still the children cry. Put a little love in your heart. If you want the world to know we won't let hatred grow, put a little love in your heart, and the world will be a better place, and the world will be a better place for you and me. You just wait and see, wait and see. Reach out and touch somebody's hand, make this world a better place. If you can, reach out and touch somebody's hand, make this world a better place. Yes, you can. Reach out and touch somebody's hand, make this world a better place. I know you can, so reach out and touch somebody's hand, make this world a better place. Yes, you can. Oh, take a good look around, and if you're looking down, put a little love in your heart. Oh, I hope when you decide, kindness will be your guide. Put a little love right here in your heart, and the world will be a better place. Yes, the world will be a better place for you. Oh, you and me. You just wait and see. Play, Alex. Yeah, yeah, yeah. Play Miss B now.
of love, yeah, yeah. Put a little love in your heart. Thank you.
We can do better than that. One more time. Woo! Put a little love in your heart. It will make the world a better place. Absolutely, I believe that. And now, ladies and gentlemen, we are going to unveil the NHRC logo, the National Health Research Conference logo. We invite Minister Tufton, as well as our acting Chief Medical Officer, Dr. Karen Webster Carr, to do the honors. Count you down. Ready, photographers? 1, after 3. 1, 2. From the top. 1, 2, 3. Thank you very much, doctors. You got it? All right. And so, ladies and gentlemen, we come to the end of the opening ceremony of our 13th Annual National Health Research Virtual Conference for the next 3 days. Wow, this is going to be amazing. I'm already looking at what's going to happen after the coffee break, and we're looking at Ministry Commission studies on salt and trans fat, very important here in Jamaica. I think I'm going to stay a little bit myself and get some knowledge, which is important. But thank you all for staying with us here for the opening ceremony. And once again, we look forward to an exciting 3 days. We're going to take a quick coffee break, and then when we return, it's the feature presentation 1 of the Ministry Commission Studies. I'm Delia Harris. Have a great day.
We were given a mandate to provide oversight of the redevelopment of the Conrad Regional Hospital. The oversight committee visited the site and inspected the building, and we all concluded that it was a worthwhile building to renovate. To construct a new building would cost 10 times as much of what we are spending to do the renovation.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. And the options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them were identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
We have not compromised on one service, one area of service that we are doing before the hospital was closed. We would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area. When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
The collapse of the Cornwall Regional Hospital posed a challenge to public health that I don't think we have seen post-independence. We engaged in a technical assessment to determine the value of what existed despite the challenges that were there, and it was determined that the building was sound. What we needed to do was to correct the air quality issues at the institution. You had to continue to use the building even with the challenges that you faced and the risks that were involved in that process of air quality issues, while transitioning and creating additional infrastructure around that main building to continue the services that were essential to saving lives. I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality building. Cornwall will one day become the best hospital in the West and probably one of the best in the Caribbean based on the work that is being done now.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility who have understood the nature of the inconveniences and why this is the case.
What will that moment of seeing that project to completion and walking into a new building feel like for you?
Well, you know, for me, it is likely to be, it will be a very fulfilling moment, without a doubt. I'll be extremely satisfied. It could be an emotional moment because we have seen the lows, we have seen the disappointments, we have seen the frustration, and to see now the success of a fully restored building will create joy and maybe even tears for some people. And for me personally, I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility who have understood the nature of the inconveniences and why this is the case. You know, I look forward to that day, and I will celebrate on behalf of all who will benefit from the restoration, and indeed take those lessons. In fact, I've asked for a case write-up of the Cornwall experience, because I think the lessons to be learned should be transmitted to all across the public health system to avoid any other institution from having the same fate. So in a sense, Cornwall Regional Hospital should be a teaching moment for us, and that's one of the major objectives that I would have in terms of moving the process forward.
Hello, Jamaica. I'm Dion Jax Miller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19 I had COVID recently and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness.
Cornwall Regional Hospital was built in 1974. It was a gift of the Canadian government. They did all the technical work and provided the resources to build the facility.
Over the years, clearly, there was poor maintenance of the building, but also the building was modified by non-experts. People were constructing offices in the corridor. What that does is to interfere with the airflow and the ventilation. There was water seeping through the roof, it was leaking, but also seeping through the walls, and there were the plumbing fixtures and so on.
As long as you have moisture building up in concrete, in wood, and so on, you're going to have some conditions that are suitable for the growth of mold. To be able to find out the extent of that problem, basically the entire building had to be gutted.
The collapse of the Cornwall Regional Hospital posed a challenge to public health that I don't think we have seen post-independence.
Closing this hospital would not be an option. It would be like closing KPH.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. The options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
In 2017, when it was deemed that staff were primarily affected by the air quality issues, we realized that we had to relocate on a phase basis and not en bloc.
We are not on the main building, we are all across the campus. We are down the road, we are over West Jamaica Conference, and we are up at Falmouth. Movement on the campus mean you have to, serving patient mean you have to move up to Falmouth, you have to move down to Barnet Clinic, you have to move across the campus. And sometimes it is very hot, sometimes it's raining.
We have not compromised on one service, one area of service that we are doing before the hospital was closed. We would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them were identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
It was a worthwhile building to renovate. To construct a new building would cost 10 times as much. And when you're renovating a building, you get many surprises. And that is what has been happening at Cornwall Regional. So you demolish a wall or to find problems which were not planned for.
We understood that there are delays. We knew that persons were disgruntled. Some persons, of course, left. But some of us decided that we're going to have to stick through this and get through it.
When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
What I can assure members of the public is that we are doing all that is necessary in terms of identifying what are required, bit of resources, bit of management system and so on. And certainly these will be incorporated in our budget in going forward.
So we're building the capacity from now. We're looking to get all the expertise we need that going forward, once the hospital is built, the whole issue of maintenance will not go back to where it was.
What will that moment of seeing that project to completion and walking into a new building feel like for you?
I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility, who have understood the nature of the inconveniences and why this is the case. You know, I look forward to that day, and I will celebrate on behalf of all who will benefit from the restoration, and indeed take those lessons, because I think the lessons to be learned should be transmitted to all across the public health system to avoid any other institution from having the same fate. So in a sense, Cornwall Regional Hospital should be a teaching moment for us, and that's one of the major objectives that I would have in terms of moving the process forward. Ladies and gentlemen, I wish to congratulate the Rotary Club of Downtown Kingston for hosting this webinar on World Diabetes Day. As we turn the spotlight on diabetes this November, we must acknowledge the scale of the problem of NCDs and redouble our efforts to solve it, drawing on all our resources, including our nurses, who are essential not only as healthcare providers, but also as professionals to whom we can rely for the promotion of self-care management among patients. Our nurses also play a role in helping to safeguard the mental health of their diabetic patients, from identifying emergent psychosocial to making the appropriate interventions to support their patients. This year's theme for World Diabetes Day, Diabetes Nurses Make a Difference, therefore is most appropriate. And in a year designated as the Year of the Nurse, this World Diabetes Day, we encourage stakeholders, from persons living with diabetes to their family and friends and others involved in their care management, to join our nurses in the effort to ensure the best possible health outcomes for persons with diabetes, and to, as far as possible, engage in behaviors to reduce the incidence of diabetes and other NCDs. Those behaviors include increased physical activity, a healthy diet, routine health checks.
Morning. Right, great. Morning, colleagues, guests. We'd like to get the next session underway on time. So it's, my watch says me it's 10:58. So if we could
I'm Dr.
take our seats with our snacks.
I'm Regional Director for the Western Pacific World Health Organization. Today, on the World Health Day, I would like to ask you.
All right, great. All right, excellent. Good. All right. Good morning again, everyone. Those of us who are here at the AC Marriott and those of us who are online, it's indeed my pleasure to reconvene and start the National Research Conference, get it on the way. So my name is Marvin Reed. I'm the Deputy Dean for Research at the Faculty of Medical Science, University of the West Indies, Mono, and I'm also co-chair of the Essential National Research Health Committee. It's indeed, again, my pleasure to get this part of the proceedings under the way. And in this segment, we will be having two presentations representing research outcomes of commission studies from the Ministry of Health and Wellness. Our speakers this morning are eminent professionals in their own right. The first will be Professor Trevor Ferguson, who is a professor of epidemiology and internal medicine, as well as the director of the Epidemiological Research Unit at the Caribbean Institute for Health Research. Professor Ferguson now serves as the chair of the Jamaica National Committee on Non-Communicable Disease and is an investigator on several research projects within the fields of cardiovascular disease epidemiology. And he will be speaking to us on the outcome of their SALT study. Following his presentation and following the question and answer period surrounding his presentation, we will proceed swiftly into the presentation by Professor Fitzroy Henry. Professor Fitzroy Henry served as the director of the Caribbean Food and Nutrition Institute for many years, for about 17 years. And he's currently a professor at the University of Technology, where, to his credit, he has developed a postgraduate program in public health nutrition. So he will address us particularly on the role of trans fat, that the study that the Ministry of Health and Wellness had commissioned on his behalf. So without any further ado, and to ensure that we are in keeping with our time, especially for those of our audience who are online, I will now invite Professor Ferguson to deliver his talk.
Okay, so thank you very much, Professor Reed. And may I have the slides? All right, we should go back to the start. Let me see, does this work? Okay, good. All right, so good morning, everyone, and let me thank the Ministry of Health and Wellness for inviting me to make this presentation and providing an opportunity for us to share with the academic community as well as other health professionals as well as the public at large as to the progress regarding research that we have been conducting at the University of the West Indies in collaboration with the Ministry of Health. So this project is called the Jamaica Salt Consumption Knowledge, Attitudes and Practices Study, and it's a collaborative research project between the Ministry of Health and Wellness, the Caribbean Institute of Health Research at the University of the West Indies, and has been funded by the National Health Fund. Now, the overall aim of this project is to obtain baseline data on salt consumption in Jamaica, salt content in restaurant foods, and to evaluate knowledge, attitudes, and practices of Jamaicans regarding salt consumption. Now, one may ask, why is this important? So let's just take a few minutes to look at the importance of salt as it relates to health and what are the potential implications of high salt diets. So most of us are familiar with salt. The chemical name is sodium chloride, and it's a major component of the food supply chain in most countries. It's commonly used to flavor food. It's also used as a food binder and stabilizer, and also as a food preservative. Now, humans require approximately 500 milligrams of sodium to carry out daily bodily functions. And these include maintaining extracellular fluid volume as well as plasma volume, and it's also important in the conduction of nerve impulses and muscle contraction. Now, where do we get salt? So most salt in the diet comes from table salt, which is chemically sodium chloride, and this is added in foods that are processed foods as well as foods in food preparation, and sometimes also added at the table. Other sources apart from table salt include monosodium glutamate or MSG, as well as sodium bicarbonate or baking soda. Now, most people consume somewhere between 9 to 12 grams of salt per day. And my slides are doing a thing of their own. Which works out to be about 3,500 to 4,700 milligrams of sodium. And it's important to understand that distinction. So salt is sodium chloride. The active component really is the sodium. So 3,500 to 4,700 milligrams of sodium. And this is 1.5 times to 2 times the recommended maximum intake. Now, as we mentioned, most salt in the diet comes from processed foods, and this is particularly so in developed countries. Also important, though, is that salt may be added during cooking as well as added at the table while food is being eaten. Also, an important source of salt is foods prepared outside the home. So when we eat at restaurants, etc., then we are also consuming usually higher than average amounts of salt. In terms of the global average salt intake in 2010, this was estimated at 3.95 grams per day. Intake was higher in men compared to women, and on the global level, intake was highest in East Asia and lowest in Sub-Saharan Africa and Latin America. Now, a high salt diet has been associated with multiple adverse outcomes, and this we illustrate pictorially by looking at the various organ systems that are affected. So when we look at the heart and blood vessels, there is high blood pressure, ischemic heart disease, hypertensive heart disease, as well as heart failure. For the brain, there is stroke and dementia. For the kidneys, chronic kidney disease and renal stones. High salt diets are also associated with stomach cancer, with osteoporosis, as well as with obesity. And taken together, these account for approximately 3 million deaths each year. Now, in terms of the trends in salt consumption, a recent study published in 2021 found that the absolute global burden of deaths attributable to high salt diets has increased significantly when we compare rates in 1990 versus rates in 2019. And this is thought to be due to growth in the population as well as population aging. And this increase was found even though the absolute age standardized mortality associated with salt consumption had declined. So in response to these potential adverse effects of salt, the WHO has put forward recommendations, and they've published a package called the SHAKE package, where they recommend that salt consumption should be less than 5 grams per day, which is equivalent to 2,000 milligrams of sodium. They recommend that countries should target a 30% relative reduction in mean population sodium intake by 2025. And as mentioned, they published the SHAKE package, which provides a set of guidelines that member states can use to implement and monitor salt reduction strategies. What about potassium? So in addition to high salt, low potassium intake is also associated with several non-communicable diseases, including hypertension, cardiovascular disease, renal stones, and low bone mineral density. An increase in potassium intake may reduce blood pressure, decrease the risk of cardiovascular disease, and mitigate the negative consequences of high sodium consumption. So the WHO recommends that persons increase potassium consumption in an effort to reduce these potential adverse health outcomes. And the recommended level of potassium intake is approximately 3,510 milligrams per day. So this study was designed to begin to address this problem. And we have 4 objectives. The Objective 1 was to estimate dietary consumption of sodium among Jamaicans using spot urine analyses. We want, secondly, to evaluate sodium content in commonly consumed foods sold in restaurants, to conduct a baseline survey on current knowledge, attitudes, and practices regarding salt intake in Jamaica, and again to estimate current levels of salt consumption, and to conduct a validation study where we compare spot urine sodium estimates to 24-hour urine sodium estimates in an effort to ensure that we have valid results when we conduct our studies. So the study, in accordance with the objectives, is divided into 4 components, and I'll give you an update on the progress that we have made with each of these components in the next few slides. So for component 1, which focuses on the spots urine sodium analyses, we have analyzed samples from the Jamaica Health and Lifestyle Survey 3, which was conducted between 2016 and 2017. From this study, we have estimated mean dietary sodium consumption, as well as mean dietary potassium consumption, as well as proportions of participants with high dietary sodium and low potassium consumption. We also evaluated some associations between the dietary sodium consumption with socio-demographic factors and other participant characteristics. The initial findings from this study were presented at the Caribbean Public Health Agency conference in September. And just to share the main findings, so from our estimate, we found that the mean sodium consumption nationally was approximately 3,582 milligrams per day. This was higher in men, 3,943, compared to women, 3,245. And these differences were statistically significant. Mean potassium consumption was 2,052 milligrams per day overall, higher in men, 2,210, and women, 1,905. When we looked at the estimated prevalence of high sodium consumption, this was found to be 67% overall. So 2 in 3 Jamaicans have high sodium consumption. This was higher in men at approximately 73% compared to women, 61%. With regards to low potassium consumption, the levels were even higher. So almost 90% or 89% of participants had low potassium consumption. Women had higher levels of low potassium consumption, 92%, compared to men at 85%. Now, in terms of prevalence of high sodium and low potassium consumption, this slide illustrates that this was consistent across all age groups. So from the youngest to the oldest, essentially all age groups had high sodium and low potassium consumption. Of course, there are some important differences which we'll not go through right now. Now, from this component, we've completed another set of analyses looking at the urine sodium to potassium ratio and its association with socio-demographic characteristics among Jamaican adults. And this paper will be presented this afternoon by one of our volunteer clinical researchers. Okay, I think I skipped one. Okay, so moving on to component 2. And for this component, we're looking at salt content in foods sold in restaurants. And what we've been able to do so far is to create a database of restaurants in Jamaica, having obtained data from the Companies Office of Jamaica. And essentially, what we have done so far, we have focused on chain restaurants, which were defined as having 3 or more branches, and we were able to identify 29 chain restaurants. And we're also looking at other individual restaurants, as well as small cook shops and food stalls in communities. So we're putting these data together, have not been able to do as much as we would like to as yet. Now, what we have been doing for the chain restaurants is to contact the restaurant managers to obtain information on meal items sold in each food establishment and to gather information on nutrient profiles, recipes, as well as ingredient listings, and also to administer questionnaires on food preparation practices. We will use that data to estimate the mean sodium content per meal and the proportion of foods with high salt content. So far, we've had limited response from the restaurant managers. I guess some persons were not too eager to share, but we're working diligently to try to get as many as we can. However, we have been able to compile a database of menu items from these chain restaurants, and what we will be able to do is to use food databases to estimate sodium content. And one of the food databases that we're looking at is the U.S. Department of Agriculture Food Central database. So we'll be able to obtain nutrient information and to do our respective classifications. Now, for the third component, we're looking at knowledge, attitudes, and practices regarding salt consumption, and also estimating current salt consumption levels. So we'll be able to say whether or not there have been changes compared to 2016, 2017. For this component, we're recruiting a nationally representative sample of 1,200 participants, administering questionnaires to evaluate knowledge about salt intake and health, attitudes regarding salt intake, as well as low salt diets, as well as current practices. So what are people actually doing? We're measuring weight, height, and we are also collecting spot urine samples as mentioned. So far, we have enrolled approximately 175 participants, and we have approximately 596 potential participants recruited and awaiting interviews and data collection. For the fourth component, which is the validation study, for this we are performing 24-hour urine collection in addition to the spot urine samples that we're collecting. And what we will then do is to compare the estimates from the 24-hour urine collection to the spot urine collection and see the levels of agreement. And we may also be able to derive equations to help in calculating or estimating 24-hour urine sodium from spot urine samples. So far, we have collected approximately 60 sets of 24-hour urine spot urine samples, and we hope to complete this by the end of this month. So overall, this study will provide information that will fulfill some of the components of the WHO Shake package. We have been able to document that there are high levels of sodium consumption and low levels of potassium consumption within the Jamaican population, and therefore there is clearly a need for public health interventions to address this. Our study will provide relevant data that will inform interventions to promote both individual as well as population strategies for sodium reduction. And the ministry has already started to draft a plan for national salt reduction. So this is our team from the Caribbean Institute for Health Research, the Ministry of Health and Wellness, as well as some of our volunteer physicians. And this picture shows our field workers out in Portland collecting data and recruiting participants. So thank you very much.
So we are now going to be going into the question and answer phase of the proceedings. And can you advise, can we, the online folks, pose questions? Is there a mechanism for them to pose questions? All right, good. So you'll advise me if there are any questions online. But while we gather and aggregate those online questions, I do have a few for Professor Ferguson, if you mind, to get the ball rolling. So the first question has to do with your urinary sodium estimate. Why are you proceeding to do a validation phase of your spot urine 24-hour? Why not just do a urine potassium ratio?
So we are doing the urine potassium ratio, and that will be presented this afternoon. In terms of the recommendations, really focus on the levels of sodium consumption as well as the levels of potassium consumption. So while there has been emerging data that looking at sodium to potassium ratio is actually quite beneficial, it is simpler and sometimes may be more predictive of adverse cardiovascular health outcomes. The basic recommendation still is focused on sodium and potassium consumption levels. So I think it is useful. So in essence, we're doing both rather than just doing the sodium and potassium levels.
All right, great. And so my follow-up question to that now relates to the phase of the experiment where you're collecting the recipes from the various restaurant chains and using those recipes to come up to derive an estimate of the sodium content of so on. Why not another approach? Just go and buy the food and do a food analysis.
All right, so the question of food analysis, that has been discussed, and we would like to do that. We did not have funding in this round to do it. We're actually looking at writing up a follow-up phase of the study in which we will seek to get food samples and do the direct assessments, which will be more valid, but of course it still will be limited. I think using the approach will give us a sort of a semi-quantitative levels on a much broader scale than we'll be able to practically do with the food samples.
All right, thank you so much. Are there any questions online? Certainly there's one in the audience. Go ahead. We need a live mic. Go ahead, I'll translate your question. Go ahead.
Okay, so table salt provide iodine. So will reducing salt intake lead to iodine deficiency?
Yeah, so that is unlikely based on what we're recommending. So in essence, you're looking at reducing salt intake to 2,000 milligrams per day or 5 grams of salt. If we are looking at that level of reduction, then we should still have adequate amounts of iodine. So the issue is that persons are consuming 1.5 to 2 times that. So in essence, it's not a no salt diet. It's really a low salt diet.
Another question. Is twin Jamaican have a high sodium consumption?
Mm-hmm.
I am interested in cutting back on my salt intake,
Mm-hmm.
but I want my food to be palatable.
Mm-hmm.
Is there a substitute for salt?
So the first thing really is reducing the amount of salt. So if, say, for example, if we're able to cut our salt intake by 20-25%, you will still be able to maintain taste. Of course, I'm not the nutrition expert, but we have lots of nutritionists around in terms of there are other natural herbs and spices that can be added that can improve the taste of the food. There have been studies where they have done salt substitution, and that's something that we're looking at exploring. And essentially what they do is that they replace about 20-25% of the sodium chloride with potassium chloride, and then that is used. And usually it can be done without having a major difference in the food taste. And for processed foods, for example, it's often recommended that it is done over time. So for example, if you're used to having your bread with X amount of salt, what is looked at is a gradual phase reduction to get to target rather than, a drastic cut. And the other important thing is that our taste buds adjust. So if you've been used to having a high salt diet and you gradually reduce your salt, then your taste buds will adjust so that you will be able to tolerate it. And actually, if you speak to some of our more diligent hypertensive patients who really have cut salt, their taste buds have so adjusted that if it's salty, they just can't eat it because it now tastes almost offensive. So our bodies are agile enough to adjust to the sodium reduction that we're recommending. So we're not going to be having bland, boring food. We'll have good, tasty food with less salt.
All right. Ms. Delio, you had a question?
Right, so we haven't drilled down on all the details, just what we could think of in terms of the a lot of the salt comes from processed foods and eating outside the home. So men tend to work outside the home more than women. Men generally don't like to cook. Well, many men. And therefore, there may be a higher intake of processed foods among men compared to women who spend more time in the home. So that may be a simple reason why we see that difference. Mm-hmm.
All right. I'll just take one final question because we're running out of time for the question. Go ahead.
All right. Thank you for your excellent presentation. Mm-hmm. My question is, when the restaurants refuse to cooperate, mm-hmm. and we as people, we consume this food all the time. Mm-hmm. I remember the professor saying, why not just buy the food and assess it for yourself? Mm-hmm. So you were talking about there's no funding for that. Mm-hmm. Okay. Now, what I want us to take a look at, the individual who eats the food. Mm-hmm. You go in the restaurant and use the assessment of those who are partaking of the meal. Could we use that as a method to judge as it relates to the level of salt content in the meal? That could be one way where we have a questionnaire for those who patronize these food places. Like KFC, for instance, did they give you their recipe? Did they cooperate? Because those are the persons, because what I was thinking, you're talking about potassium and sodium. Now, naturally, we know that potato has potassium. So putting salt in it, we kind of bring a balance. So are we going to be assessing these? Because if you're telling somebody, we have generally low potassium, high sodium. So there's an imbalance already. So to create that balance, so somebody say, I know that the potato naturally has potassium. So adding a little salt in it is okay. It kind of brings that balance. So what are you going to say to somebody in that category?
All right, so let me see if I can tackle that. Well, the first thing I want to really make very clear, though, is that as part of our research, we emphasize confidentiality. So when we interview particular restaurants and so forth, in our reporting, we never report which restaurant or which company says X, Y, Z. So we have to protect that confidentiality. So that's very important and an important principle in research. Now, we can get subjective responses from participants, but again, it's because sometimes the most salty food don't taste salty, you may be very deceived. So we can definitely use the methods of actually doing food sampling and doing that assessment. What we want to get at ultimately, though, is to have regulations so that companies are required to disclose the nutrient content of the food. So if I walk into a restaurant, it should be available to me to say that this particular food item has X amount of salt, X amount of fat, and so on, and then I can make an informed decision. So ultimately, we would want to have that those information are available, whether it's in the form of an app, whether it's a brochure, or it is actually on the menu, and so forth. Ultimately, we would want to have some sort of regulations towards that. But we are quite a bit away from that. We're still struggling with front of package labelings for processed foods. But we will definitely need ultimately to get to the place where restaurant foods also provide nutrient profiles. Just to say that, as we've mentioned, that for many of these foods, there are databases that are available that can provide information. So for the informed consumer, you can find the app on your phone and you walk into a restaurant, and before you make a purchase, you can check what's the salt content, what the fat content, how many calories per serving, so that you actually know what you're doing. So we can take action, but what happens now is that we're dependent on external databases rather than the local databases. So in terms of how reliable this is at this point in time, there may be a little bit of uncertainty, and hopefully we'll get to the point where we're doing regular food sampling so we can be confident that when we see X on a label, we know that that is what is actually taking place.
Thank you. One last one. What do you recommend? Can we stop eating processed food and we just prepare our meals by ourselves, especially the men? What do you say?
We will try.
Thank you.
All right. We'd just like to, on your behalf, thank Professor Ferguson for walking us through some of the results and the goals of the SALT study. It's indeed my pleasure at this point in time to welcome virtually Professor Fitzroy Henry for his presentation on trans fat.
Thank you. Good morning, and thank you, Professor Reed. I take it you are hearing me, yes?
Yes, we're hearing you.
Wonderful. Okay, good morning. Thank you again, and good morning, colleagues. I wish to thank the organizers of this 13th Annual Health Research Conference for inviting me to present on the trans fat study. The theme is combating chronic disease, and I think we all agree that we cannot have a healthy future if we do not remove trans fat from our food supply. The sponsors of this work are the Ministry of Health and Wellness through the National Health Fund, the FAN project, which was funded by IDRC, Resolve to Save Lives, known as the LINKS project, and the University of Technology. My main colleagues, I should say, several persons were involved, were Rashid Perry, from the University of Technology, and Mr. Dwight Bremer, who is the manager for the Chemistry Department Division at the Bureau of Standards. Okay, so what I want to do in this presentation is to just give you a brief for those who still do not know why we are focusing on trans fats, and the main results really of how bad it is in Jamaica, and whether our labels are accurate, what we can do about that, and where do we go from here in terms of our national and also regional and global targets. Let me make it clear that fats are important. I don't want us to put everything in the same bucket because they are good for all kinds of things. In fact, 60% of our brain is fat. I need not say more. But the problem is not only too much fat, but the wrong kinds of fat that we consume. And of course, when we consume those wrong ones, we can increase the risk of serious illness and health. And this is a slide just to familiarize you or remind you that we're looking at fats, particularly the trans fat, which is to the extreme right here. And there are two types of trans fat, those which are natural, or what we call ruminant trans fats. And what I'm going to focus on is the industrially produced artificial trans fats. So the first part, why focus on trans fat? We focus on it because it is bad. It increases the bad cholesterol, the LDL. It causes high blood pressure, heart disease, cancer, and other things. And it lowers the good cholesterol. And it has a number of other bad things. But the ones that are definitely related to the chronic disease, which we are focusing on, communicable diseases, is really what it does to the good and bad cholesterol. And when we look at an old study from Wang, well, it's not so old, it's 2016, when we look at the monounsaturated and polyunsaturated, they're actually looking at the change in total mortality. You see that those are, if you like, the good fats. And when we look at saturated fat, we see that it increases the risk of total mortality, and trans fat is even worse. So we have the good, the bad, and the worse. And this is why trans fat needs special attention. And it's good that we have, after a long time waiting, we've been able to get some results on how much of this bad or worse trans fat that we are consuming. So why are trans fat used if it is so bad? Well, it makes food easy and stay fresh on the shelf for much longer. The shelf life exceeds the other types of fat. It improves the texture of the food and the flavor. Stability is also maintained over a long time. It is also cheap and cheaper than the other types of fat, and it can be reused quite easily in deep frying. So this is really attractive to manufacturers. And we need to find out whether or not our favorites are safe, because we know that these are the attractive foods and desserts that we all consume. So in this study, we wanted to determine the concentrations of fatty acids in general, and we looked at 308 commonly consumed foods in Jamaica. And from the whole range of fatty acids, I'm only going to focus on the trans fat for the limited time that I have to present. We used the WHO protocol for sampling, collected from supermarkets, wholesales, fast food restaurants. The foods most likely to contain industrially produced fatty acids were grouped into categories. There are different types of popular brands for each category, and 3 consumer-sized packages for each brand were collected. The method we used was the gas chromatography. It looks something like that, but in fact, in terms of its operation, basically, we have the gas here, flow of gas from a gas tank. It goes through this oven, as we call it. We put the sample here, and through a process, it detects the different types of fats, and it is a printout comes with different peaks. And from those peaks, we can differentiate the different types of fatty acids. And we can also separate the natural from the artificial trans fats. And this is a method that is used by the American Oil Chemist Society of analysis. So let us look at some of the results. Now, most of the results are using a denominator of total fat. So first, let us look at the amount of fat that we have in the 308 samples. Almost all of them, if not all of them, had fat in them. But what we wanted to do is to look and see how many had high levels of fat. There isn't an international criterion for assessing high levels of fat. So we actually use the National Health Service, the UK threshold of 17.5 grams per 100 gram of food. And what we found is that 84 of the 308 samples had high levels of fat, which is about 27.3%. And the foods that had, or the food categories that had high levels of fat, as you'll expect, cooking oil, 100%. And then we had a number of other food categories with high levels of fat overall. Then the next question is, what proportion of the samples contained industrially produced trans fat? In other words, the artificial fat. And we found 104 of the 308 samples, which is about 33.8%, had this industrially produced trans fat. And it came from 52 companies that had trans fat in their products here in Jamaica from the samples that we are looking at. 52 companies. So, which food categories had samples with industrially produced trans fat? Confectionery had the highest, then cooking oil, snacks, condiments, and so on. And there were some categories that did not have industrially produced trans fats. And then the next question is, what proportion of the samples, of all the samples, had high levels of industrially produced trans fat? And we used the PAHO criterion of more than 2 grams per 100 grams to be considered high levels. And we found that 7.8%, in other words, 24 out of the 308 samples had high levels of industrially produced trans fat. Let me just make the point that even though these are individual samples that had these high levels, we must remember that trans fat accumulates. So even though there are other food items that are less than the 2% PAHO limit, when you eat different combinations in a given day, you can easily go over that limit. But these are just the individual samples that had more than the 2% PAHO limit or threshold. And they came from dairy, with 20% of them were above the PAHO threshold, 11.5 canned meats, and we see the others coming down. And then we also wanted to know, of those with industrially produced trans fat, how many of them had high levels? In other words, just looking at those with trans fat, how many within them had high levels? And we see 75% of those with trans fat had high levels with dairy, baked foods, and so on as it came down. Now, this is really disturbing, as I hope you agree. Large amounts of industrially produced trans fat in commonly produced foods here in Jamaica. And then we ask, are there specific foods within those food categories with the high levels of trans fat? And just to point out some of them, among the baked goods, we had leavened bread. We have among the cooking oils, coconut oil, which is really interesting because coconut oil, as you know, is predominantly a saturated fat. But with the imports from several countries, lots of combinations go into what they're putting out for sale, clearly, because you wouldn't expect coconut oil to have, among the various oils, vegetable oils, we don't expect them to have trans fat, but there it is. In terms of condiments, mayonnaise, breakfast cereals, very much the sweetened ones, fast foods, chicken nuggets, burgers, patties, even though our franchises tell us that they do not have any trans fat in their products, because they use the protocols from headquarters, when we do the analysis, we still find high levels of trans fat. And among the snacks, quite a variety: cookies, sweets, crackers, biscuits, potato, veg, and so on. I want to look a little bit now on the labeling. Now, the samples with trans fat on the food label, only 187 mention trans fat at all. Those that mentioned trans fat and said there was no trans fat is 180 out of those 187. In other words, 96% of those that had a trans fat label said there was no trans fat in the product. When we looked at those that said no trans fat, we found that 104 of that 180, in other words, 57.8%, had trans fat, even though the label said zero trans fat. Now, you may be aware that in some countries, there is a leeway of labeling trans fat free. In other words, if, for example, in the United States, the product has less than 5.5 grams, it is allowed to be considered trans fat free. So even if we use the US standard, we found that 6.7% of them were not meeting that 0.5 gram standard. In Canada, it is more stringent, and they allow 0.2 grams, anything less than that, to be labeled trans fat free. But in our samples, we found that 12.5%, even if we use those labels, those criteria. Now, we have not yet decided in Jamaica what we are going to regard as trans fat free. If we're going to say absolutely zero trans fat, or if we will follow North America and say, okay, you can label it trans fat free if it has whatever percentage or whatever grams of trans fat. That is something that's in the works. I'm not sure how the industry partners are going to want to put a value or a standard on that, but that is work to be done later. So, as Minister said this morning, we have to figure out whether we are bold enough to do certain things regarding non-communicable diseases. And we have started by looking at the analysis, and I presented some work on that. We can do much more and collect, maybe more regularly or a wider range of samples and do more analysis, but at least we have a good collection of those that are likely to have trans fat. What we're doing today and what we have been doing in several workshops and conferences, and looking at how we get the information out even to the food manufacturers, because many of them don't even know that their product has trans fat in them, but that's another story. But we really need to do the education of different stakeholders through mainstream broadcasting and also through social media. I have just started a webpage, and also I have it on Instagram and Facebook, even TikTok. It's not very sexy as you can imagine, but I still have it on some posts on TikTok and Facebook, because as Minister said, we have to move beyond the journal presentations, which is coming out soon in the PAHU journal, the results of this. But persons in the street don't read, the British Medical Journal and Lancet and so on. So it's a matter of getting this information out. So we have to continue these conferences and presentations and workshops. But then we have some other challenges, like the reformulation that needs to be done by the manufacturers. We also have to look at labeling I hope you found that labeling information disturbing. As you know, we do not even have the back of package, the nutrition labels as mandatory in the Caribbean, let alone the front of package labeling, because the front of package is based on the back of package. In the back of package that we have right now, you see what is there. So are we bold enough to push for this? Because this is all part of the right of the public to know what they're putting in their mouths. And of course, we have to continue monitoring by taking samples from time to time to make sure that there is compliance. So it's a lot of work in red in particular that we need to start. We need to continue what's in blue, but we have to really to start. And are we bold enough to do that if we're serious about having a bright and healthful future? Let us look at a couple of slides now in terms of what other countries have done. Ireland, looking at processed food products. In 2008, 20% of their products had more than 2% trans fatty acid as a percentage of total fat. And 8 years later, it was only 2% of the products had that level. And they did that through mandatory labeling. In Canada, between 2005 and 2009, 25% of their products had more than 2% trans fatty acid. Between 2010 and 2011, only 3% of the products had that, and it was found particularly in croissants and pies, cakes, and garlic spreads. And their policy intervention was mandatory labeling. Since then, Canada has totally banned artificially produced trans fat in 2021. In New York City, there's a restaurant regulation, and they had mean trans fat per purchase decreased by 2.5 grams. The mean trans plus saturated fat content decreased by 1.9 grams. The mean fat decreased by 2.7 grams per 100 kilocalories. And the purchase with 0 grams of trans fat increased from 32 to 59%. So those purchasing with 0 trans fat, given the limitations in America of 0.5 grams, it increased. And their policy prevention was mandatory labeling.
Professor, could you be wrapping up now, please?
Last slide coming up.
Good.
And so in several countries, there are mandatory limits. And these are several countries that have those mandatory limits for trans fat. In the Americas, US, Canada, Brazil, Peru, they're all banned trans fat. US and Canada require trans fat labels on packaged foods. Argentina, Chile, Bolivia, this is in the Americas. In the Caribbean, the question is, what are we doing? Are we doing sufficient? Who has a trans fat-free America next year? And the question is, can we meet those regional global targets or even our national targets if we put them in place? And this is just to show you the website, facethefacts.com, and I also have it. If you're interested, I can give you the handles for those. So thanks to the FAN project, Resolve to Save Lives, Ministry of Health Wellness, National Health Fund, and the University of Technology. Thank you, Professor Reed, for being patient with me, but that's the end of the presentation.
Thank you so much. All right, so colleagues, unfortunately, we have a bit overstayed our welcome a bit in terms of the timing. I'm sure many of you will have questions for Professor, and the contact information, as he demonstrated in his slides, are available there, as well as his contact information would be available through the program. So we can continue that conversation. So clearly we do have a problem, as been outlined. Clearly we will have to move fairly rapidly towards the appropriate regulations that we're going to be needed for this particular issue of trans fat in our diet. And we thank Prof. and his group for bringing the matter to our attention. So colleagues, on your behalf, I'd just like to thank you for participating in this, our first session, where we presented on studies that were commissioned by the Ministry of Health. And I will now hand you over to the moderator for the next session to continue through the program. But before that, I see Dr. Grant with some packages and goodies. Hopefully they have no trans fat in them. I'm told confectionaries are one of the highest content of trans fat. I'll invite Professor... Oh, this is mine. Oh, okay. All right. Feel free.
So this is actually a surprise to Professor Reed, but we want to say a great word of thanks for the support, not just of the Health Research Conference, but research in general. Prof. Reed is now our Chair of Essential National Health Research, and we do appreciate him. So please give him a round of applause. Thank you.
Hopefully zero trans fat. And no salt. All right. Are there any other presentations? Want to come? Come along.
So, Prof. Ferguson, the bag doesn't look as exciting, but you have to look inside to see the contents. And we do appreciate that you have taken the time to elaborate on the Ministry of Health supported studies, and we look forward to the continued interrogation of that data. So thanks again, Prof, for all that you have been doing.
All right, and with those presentations, again, on your behalf, thank Professor Ferguson and Professor Henry for their presentation. And we move now to the next part of the program.
Good morning, everyone. Welcome to Scientific Session 1 on Nutrition. I am Marshall Turnipit, and I'll be guiding you through the session. For this session, we have 4 presenters: Dr. Sophie Abrican, Dr. Sharon Dawson, Dr. Novi Younger-Coleman, and Dr. Andreen Grant. Please help me to welcome them to the platform. Dr. Sophie Abrican is a family medicine practitioner currently working at the University of Technology's Medical Center. She has been in primary care practice for over 14 years. She enjoys family medicine and is a final year resident in the Family Medicine DM program at UWI. Dr. Sharon Dawson has worked in public health for over 30 years and has a PhD in human nutrition from the Department of Medicine at UWI Mona. She has co-authored and written several papers that have been published locally and internationally, and she has also co-authored a textbook for School of Dentistry at UWI. Dr. Novi Younger-Coleman is a qualified statistician and senior lecturer in biostatistics in the Epidemiology Research Unit at the Caribbean Institute of Health Research. She is also the first vice president of the Jamaica Statistical Society. Dr. Andreen Grant is the director of Epidemiology Research and Data Analysis Unit within National Epidemiology at the Ministry of Health and Wellness. The unit serves as the Secretariat to the Essential National Health Research Committee, responsible for developing a national health research agenda and a COVID-19 research agenda. She also leads the Secretariat for the annual National Health Research Conference. She served as an investigator for the 3rd Jamaica Health and Lifestyle Survey. Dr. Grant has authored and co-authored papers, reports, and scholarly presentations. She is passionate about strengthening the national health research system, as well as building partnerships in the furtherance of research to inform policy and practice. Again, let us welcome them to the platform. Our first presentation will be facilitated by Dr. Sophie Abrican, and she will be doing a presentation on attitudes towards and barriers faced by primary care physicians in Jamaica regarding provision of chronic illness preventative nutrition care. Okay. Welcome, Dr. Abrican.
Good morning, everybody. Thank you so much for being here. It's kind of hard to come after all of these greats, but I'll do my best. Okay, so today I'll be presenting on attitudes towards and barriers faced by primary care physicians in Jamaica regarding the provision of chronic illness preventative nutrition care. As we already know quite well, chronic diseases of lifestyle and non-communicable diseases, or NCDs as they're often called, have really significant increase in the last century, and with them, of course, have carried a lot of morbidity and mortality. In 2016, NCDs were the cause of 41 million deaths, and NCDs have been linked in the Caribbean to 7 out of 10 deaths. So looking at the local picture, we're also not very far behind, as you all know. According to the third Jamaican Health and Lifestyle Survey for the period 2016 to 17, diabetes prevalence was at 12%, hypertension prevalence at 33.5%, and over half of the population was overweight or obese. And in addition, as Professor Ferguson talked about too, 1 in 10 Jamaicans consumed excess salt in their diets. So really, what is the role of the primary care physician? Well, international best practice guidelines have stated that it's actually our duty as PCPs to give nutrition care. And in fact, this care really is effective in improving our patients' dietary behaviors. So even small changes that we can help them with and to improve their dietary behaviors really can improve patient outcomes significantly. And that in turn can also decrease the amount of chronic disease we have in our population. But even though we know all of these positives, in reality, unfortunately, there's really a big gap between what the public needs in terms of nutrition advice from their doctors and what they actually get from their doctors. And all across the world, studies confirm that PCPs believe that nutritional counseling is effective and they have a role to play in this type of care for their patients. But as in life, there are always barriers. And unfortunately, their physicians have stated there are several barriers that prevent them from giving this type of care properly. So they have said that there's a lack of time and reimbursement. They feel they have inadequate knowledge. They don't have enough training, skills, confidence. And of course, the big one, they always feel they have not enough resources and there's not enough evidence-based interventions for them to use. And of course, as you would imagine, there are patient factors. So patients can be non-adherent, and there's also these type of consultations also can be more expensive. So why did we want to do this study? Well, we already know that NCD burden in the Caribbean is large, and it's not getting less, it's increasing. And based on looking, we couldn't find any similar studies locally or regionally, so we thought that it was an important topic to focus on, and maybe we could help to fill an important research gap. So for this study, we wanted to determine the attitudes of primary care physicians towards chronic illness preventative nutrition care, or CIPNC, it's a bit of a mouthful. And we also wanted to determine what barriers these PCPs face when they're delivering this type of care. So this study was a cross-sectional one, and the eligible participants were primary care doctors that were working in Jamaica in both public and private systems. We collected data this year between June and July, and the plan was to use, because of, at the time of inception, the COVID pandemic was a big thing, we used an online self-administered questionnaire. So data were collected as part of a larger study on demographics, physician knowledge, attitudes, practices, and suggestions for improving preventative nutrition care. For the purposes of this presentation, though, I'll only be talking about attitudes and suggestions for improving preventative nutrition care. And we got ethical approval from the Mona Research Ethics Committee and also from the Western and Southern Regional Health Authorities. So the main tool that we used was a lifestyle questionnaire tool, and that was used with author permission. And it included 12 questions, which were on a 4-point Likert scale, with 1 being equal to absolutely agree and going right up to 4, which was equal to absolutely disagree. So just to note that barriers or perceived barriers by these doctors were reflected by some of the attitude questions we asked, and also in the recommendations that these doctors made for improving preventative nutrition care. So just for this study, though, we defined PCPs, or primary care physicians, as GPs, general practitioners, family medicine residents and specialists, internists, as well as geriatricians. We didn't include pediatricians in this case. So data were analyzed with the Social Sciences Statistical Package Software version 20. Categorical variables, we reported them as proportions and percentages, and for the open-ended responses, we placed them into categories based on the common themes that we found. And also attitude items were also converted to continuous variables and reported as mean scores. For example, a minimum mean score was 1 and a maximum mean score was equal to 4. And higher scores were representing greater agreement, were representative of rather greater agreement and more positive attitudes. So on to the results. There were 179 doctors that responded, and of these, the greater proportion of 31.5% were from the 30 to 39 year age group, and the smallest proportion of 9.6% were from the 20 to 29 year age group. Most were females, 65.4%. As you would imagine, majority were Jamaicans, 84%, and a little over half had been practicing for more than 10 years as a PCP, so it's a pretty experienced group. In terms of where the GPs or the PCPs worked, 49.2% worked in the private sector only, 21.2% worked in publicly, and 29.6% worked both in public and private sectors. Most of them worked in Kingston, St. Andrew, and St. Catherine, and about half had postgraduate medical degrees. So again, a pretty experienced, educated group. So importantly, looking at these doctors' attitudes, what were their attitudes towards their roles in chronic illness preventative nutrition care? Well, I was really, really encouraged to see, I must say, amongst my fellow doctors, that there was a really high level of agreement related to the attitude items, and that indicated that they really showed very positive attitudes towards chronic illness preventative nutrition care. For example, 75% of the PCPs agreed with the statement that my profession includes not only treating disease, but counseling and lifestyle as well. And 90% of them agreed that nutrition counseling is really very effective. A further 95% agreed that patients expect physicians to be role models in their own personal health behaviors, and 86% agreed that in their own personal lives they practiced a healthy lifestyle. I was again happy to see that. Also related to the statement that patients can be motivated to change behaviors regarding stopping smoking, losing weight, or increasing their physical activity, there was a really overwhelming agreement among the PCPs, 95, 94, and 95% agreement respectively. And higher mean scores, just to remind you, for the attitude questions reflected more positive attitudes, and interestingly, the highest mean score was related to physicians agreeing that in their personal lives they practiced a healthy lifestyle. So, related to reasons why many doctors did not do nutrition counseling, well, surprise, surprise, most of them, 76%, agreed that this was due to lack of time. And half of them agreed it was due to lack of knowledge, and about 41.7% agreed that it could be due to lack of interest. Fewer PCPs, though, agreed with nutrition counseling not being done because they didn't believe it was effective or because their employer didn't compensate them for the service. And really only a tiny proportion, thankfully, of 5.7% agreed that nutrition counseling wasn't done because it wasn't their duty. And correspondingly, the lowest mean score related to the statement that physicians do not counsel their patients regarding good nutrition because it wasn't their duty. So, Again, I'm going to say I was really impressed with this part here because about 85% of the doctors responded to an open-ended question, which was asking them for suggestions to improve preventative nutrition care. And many of the suggestions are really very, very detailed, but of course I couldn't share them all here. But on the other hand, it does suggest that there really are a lot of barriers that they're facing to try to provide this care in reality. Some of the key suggestions that they made were incorporating nutrition education into undergraduate medical school training. They emphasized we need to address barriers to care. They also said they need brief and effective interventions in the office. Increased accessibility to nutritionists and a multidisciplinary approach was really emphasized too, especially for the doctors, they said, in the public sector. Government support, as usual, was also being sought, and one PCP even suggested encouraging patients to grow home vegetable gardens. So in conclusion, these PCPs really represent a very nutritionally aware group, and most of them have positive attitudes and a sense of duty towards chronic illness preventative nutrition care. But of great concern, there are lots of barriers that are threatening the delivery of this type of care by these local doctors. And many of these barriers really are similar to what we found in the international studies, but there are some additional ones that could be unique to what's happening here in Jamaica. So what do we recommend? Well, evidence-based, practical nutrition education at all the undergraduate, postgraduate, and the practicing physician levels should be undertaken. And addressing barriers that these physicians are facing really is crucial to getting somewhere. By improving our PCP skills in delivering this type of care, chronic illness preventative nutrition care in their daily practices, really we can improve patient outcomes. And with fewer barriers and improved PCP skills, we can therefore help to decrease the local chronic disease burden. Thank you so much for the opportunity and for my co-authors and to the Family Medicine Department. Thanks a lot.
Thank you for your presentation, Dr. Abrican. We'll take questions that you may have for Dr. Abrican after the next presentation. Our second presentation is on the nutritional status of primary and secondary school children, and this will be facilitated by Dr. Sharon Dawson.
Good afternoon, everyone. Okay, my presentation is entitled The Nutritional Status of Primary and Secondary School Children, Cohort 1. It's actually out of the Jamaica Moves in School program by the Ministry of Health. This is out. This is out. I can't see it. Okay. Okay. Okay, there continues to be an increase in prevalence of obesity among adolescents in Jamaica. The Global School-Based Student Health Survey 2010 and 2017 respectively showed that there was an increase in obesity from 6 to 10.1% in adolescents 13 to 15 years. The prevalence of obesity in this age group increased by 68%, and also the prevalence doubled in boys from 5.3 to 10.3% over the 7-year period. Overweight increased by 29%, mainly due to an increase in overweight in the boys. The goals of the Jamaica Moves in School program, firstly, is to strengthen the capacity of the school community to become a healthy setting for learning and working. reducing the susceptibility to NCDs among children and adolescents aged 6 to 17 years, and building the capacity of schools to create an environment that supports healthy lifestyle practices. The strategic objectives within a 5-year period is to increase the number of students engaging in moderate levels of physical activity by 5%, to increase the number of students that make healthier food choices by 5%, and to increase the number of schools that have integrated identification of at-risk students for NCD and facilitate appropriate interventions by 20% from baseline. The sample selection. 96 schools participated in the Jamaica Moves pilot intervention study. Population data randomization was used in order to select the number of students to be taken from each grade level. And the formula that was used was number of students in the grade divided by the school population times 27 over 100. Based on approval using parental informed consent form and randomizations, students were selected from each class in order to achieve the total population of 27 students from each school. Data management and statistical analysis. Data entry was done using Google Form. The data was transported to and analyzed using SPSS and Stata. Means and proportions were used to describe the population, and t-tests, chi-square, exact tests, and other tests were done, including ANOVA, in order to test for associations between the variables of interest. The population profile. We were able to collect from 2,411 students, we got BMI for age data. This was from 89 of the 96 schools across the regions. The population age range from 5 to 20 years with a mean age of 12.3 years. There are more females than males in this study. We actually had 60.8% of the population being females. Graphically showing the population of males to females, and then we looked at the nutritional status of the population. And what we got was that 17% of the student population were overweight, 15% were obese, 3% were severely obese, 1% had 1% were thin, 2% were thin, and 1% was severely thin. Let's look at the nutritional status by region. And what we saw was that the population by region, the southern region had a 19.1% overweight. The SERA was 11.3%, and that was the highest for the percentage obese. Severely obese, the western region had the highest percent, and this was 3.5. For thinness, it was the northeast region. This was 2.3%, and for severely thin, the southeast region at 0.8%. This just summarizes what I just said in the previous slide. So let's look at the nutritional status by gender. The females definitely had more overweight, more obese, and more thinness than the males. When we looked at the mean age for the nutritional status, this was very frightening because for severe obesity, the mean age was 10.8. This slide shows us that the age range for overweight, obese, severe obesity, thinness, and severe thinness ranged from 10.8 to 13.1. Again, the nutritional status by age, graphically, we saw over 30% of the students in this age group from 5 to 14 years who were obese. School category, the schools were divided into primary, all age, they were grouped together, and the high and technical high was grouped together. Based off the age range we saw, it was no surprise that for overweight and obese, the primary and all age schools had the highest prevalence. With regard to the thinness, they were about the same, 2.5%. When we looked at the severe obesity, again, the primary school age children had 3.9% as opposed to 1.8% for the high school. Thinness was also high for the primary high schools, but for severe thinness, it was the technical and high schools at 0.7%. Summary. 4 variables were statistically significant with regard to Z-score interpretation. Students' gender, females had a significantly higher prevalence of overweight and obesity than the males. Student age, students 10, 11, and 14 years had the highest prevalence of overweight and obesity and severe obesity, with the 10 to 11 years having a prevalence of 18.3% and 15.7% for overweight and obesity, respectively. With regard to school categories, the primary and all-age school students were significantly more overweight and obese than the children from the technical high schools. School grade 5 and 3 students had the highest prevalence of overweight, 21.3% and 19.4%. Grade 9 students' overweight prevalence was right behind that at 18.3%, and students from grade 4, 6, 8, and 10 all had prevalence rates higher than 15%. Conclusion. Overweight obesity was observed in 29.7% of the 2,411 school-age children that were assessed. This continues to be a major public health problem and of great concern. The younger primary school-age children, 10 to 11 years, had the highest prevalence of overweight and obesity. On disaggregation of the data and using additional variables, there was a statistically significant association between parishes and nutritional status, and school type and nutritional status for both the males and the female students. I'd like to acknowledge all who played a significant role in getting this audit done, and the data analysis and report, the nutrition officers, the parents who signed the informed consent form, the children who were very compliant, Ministry of Health staff, particularly the teachers and principals who accommodated the staff, and of course our EPI unit. Thank you.
Thank you for your presentation, Dr. Dawson. The floor is now open for questions from our participants in the room and those online for both Dr. Abrican and Dr. Dawson. Do you have any questions?
Thank you very much for your excellent presentations, Dr. Abrican and Dr. Dawson. My first question goes to Dr. Abrican. The doctors, they are willing and eager to support their client, the patient, about nutrition. And you know the saying that say 1 apple a day keeps the doctor away. So are they really willing to encourage that nutritional status? Because we know that when the individuals truly are well fed, they will have no need to visit the doctor. That is one, all right? Then the next one is teaching, the teaching of doctors about nutrition as part of their study. I think that is very, very impressive, if that can be incorporated, because that will make a whole lot of difference. And then assessing what you presented, which was excellent, that if the doctors truly, policy made, train on nutrition, then it's going to make it easier overall on our health as a population. And that brings us to Dr. Dawson's presentation. So is it okay to say that because you were in the all-age school, then you were more susceptible to being obese based on the data, based on the population? Or is it just the demographic?
It is probably a bit of both, but when we looked at the grades that were affected, if you think about the system now, from about grade 4, the children are concentrating on PEP and start doing PEP exams, leading towards the final grade 6 exam. And from what I'm aware of and what is known is that they are usually pulled off from activities, physical activities, the football practices, because it's all geared towards getting the grade 6 exam passed. So from my end, when I looked at it, that was the first thing that came to me, that they are being pulled off with regard to physical activity because they are concentrating on the grade 4 PEP exam, the grade 6 PEP exam, so they are not allowed to be as physically active. I'm not sure also if maybe the primary all-age schools have more of the foods that would enhance overweight and obesity. That we'll have to look into.
Okay, thank you. And the thinness, I was concerned about the thinness. Is it like those ones were not being fed?
The thinness, I am not sure because we did not collect data as to their dietary habits. But it was few, need for concern. But let me just also point out that all children who we assess and there was some nutritional deficiency, they were referred, whether to their health center or to their private doctor for, of course, clinical analysis and management.
Thank you. That would have been my next question. Thank you.
Okay, thank you. Is there any other question? We're able to take one more. Is there any from our online participants? No. All right. Thank you so much for your participation. The third presentation will be on the nutritional status of the Jamaican elderly, and this is results from the Jamaica Health and Lifestyle Survey 3. And this presentation will be facilitated by Dr. Novi Young-Coleman.
Okay, good afternoon, everyone. I'm sorry the title slide is not being shown, but I'm doing this presentation on behalf of the lead author, Dr. Shelley McFarlane, and other members of the team of investigators for the Jamaica Health and Lifestyle Survey 3. And we're focusing on the nutritional indices or nutrition indices in the elderly in Jamaica. So by way of background, globally and regionally and locally, there is a growing aging population, and the World Health Organization does project that the proportion of the elderly will almost double between 2015 and 2050. Life expectancy has increased from 40 to 72.6 years since the mid-1900s. And Jamaica has also experienced demographic changes with a 15% increase in the 60 plus age group since 2000, or between 2001 and 2011. And this slide here is just illustrating the projected increase in the proportion of the different age groups, particularly those 60 or 65 years and older. So there's that noticeable increase, while some of the younger age groups are expected to decrease. Now, most cardiovascular and endocrine diseases are common in the elderly, and they are also related to lifestyle. The elderly are also prone to malnutrition, and the aging process does alter a person's nutrition needs. The cardiovascular and endocrine diseases, which are common in the elderly, are also related to diet. So there's quite an interlinking of, diet and health, particularly in the elderly. So dietary changes can have a greater impact on the elderly, but we also know, it is known that, of course, if we reduce salt intake and the intake of saturated fats and increase fruits and vegetables, we can reduce cardiovascular risk by about 30%. So it has implications for how we can manage the nutrition of the elderly. So for this particular study, it's early, it's an early stage of an investigation, I would say. And so it presents, the data we present today provide estimates of the frequency and distribution of the diet and nutrition indicators among Jamaicans 60 years and older. The data were provided by a cross-sectional interviewer-administered survey. The study participants were recruited using a multi-stage sampling design with the enumeration districts as the primary sampling units. A sample of 3,100 participants was targeted, and it was believed that this sample could give valid and useful estimates for hypertension, diabetes, and obesity. And in the end, it also anticipated non-response. And in the end, we were able to recruit 2,807 participants who provided us with data. The data we used for this particular aspect of the study captured food security, dietary intake, anthropometry, hematological indices, and demographic data. No doubt the lifestyle survey gathered data on other aspects of health and lifestyle as well. The food security data was gathered using a food security scale from the U.S. Department of Agriculture, and so the data allowed us to classify individuals as having high, low, or very low food security, depending on the scores that they received using this scale. Dietary intake was gathered using a type of a food frequency questionnaire. Participants were asked about their intake of food items, including fruits and vegetables. And anthropometry, hematological indices, and demographic data were gathered as shown there. For this study, we regard the elderly as persons 60 and older. Prevalence estimates were obtained and compared for this study, and we applied the sampling weight so that the estimates can be regarded as true for the Jamaican population. So there's no real difference between the distribution of the elderly when we look at the males and the females, but the rural areas have more elderly persons, 18.5% compared to 12.5% in the urban areas. Fish consumption, vegetable consumption, legume consumption differed when we looked at those over and under 60. More frequent consumption occurring for fish consumption, for some aspects of legume consumption, and more optimal vegetable consumption more common in the elderly. Sugar-sweetened beverages, we have some differences there. At least the more frequent consumption is lower in those who are older. Fast food consumption, less common in the elderly. Tendency to add salt to meals at the table tend to be less common in the elderly as well. Food security, we have slightly higher, very low food security is more common in the elderly. And so we have over 70% of those who are older or in the 60-plus age group, this would be 60-plus, beg your pardon, being food insecure. No real difference in the BMI category distribution. Anemia levels are different when we look at the age groups, somewhat higher in those who are 60 and older. Sex differences in the 60-plus age group. Now we see that the males appear to be carrying more anemia, but the difference is not statistically significant. But diabetes prevalence, hypertension prevalence, and dyslipidemia, pardon the spelling error, is higher among the females. So statistically, no real difference for anemia. No real sex difference, that is. This is an attempt to show how things have changed over the years. Sorry, it's not projecting very well. So among the females, can we point? Oh, there we go. So among the females, for example, 70-odd% are classified as overweight, and that hasn't changed as we've moved through the 3 surveys. It's dropping somewhat for the males. They have the lower prevalence over the years. And so our results do suggest that we have a high proportion of Jamaican elderly who are overweight. The data showed 50-odd%. Somewhat consistent with other bodies of work, for example, that produced by Shearer et al. 18% of the elderly are anemic or classified as having anemia, slightly different from that which is presented in other bodies of work, lower, but for another local study by Professor Eldemar Shearer, but similar or close enough to global estimates. The 70% prevalence of low or very low food security in the elderly is of concern, and that is definitely higher than the 23% reported globally. Other studies suggest that the elderly are 4 times more likely to have low food security than their younger counterparts, and so this is something we need to give attention to. Thank you very much for your attention.
Thank you for your presentation, Dr. Younger Coleman. The final presentation will be on the prevalence of anemia in Jamaicans 15 years and older, and this will be facilitated by Dr. Andreen Grant. So it's the final presentation for this session. Welcome, Dr. Grant.
Good afternoon, everyone. I will be presenting on the prevalence of anemia in Jamaicans 15 years and older. I would like to take time to acknowledge my co-authors, as well as to indicate that this presentation is being made on behalf of the Jamaica Health and Lifestyle Survey team of investigators and collaborators. Hemoglobin is the major oxygen-carrying protein in the body, and anemia results from a condition where the number or oxygen-carrying capacity of red blood cells is insufficient. Low levels of hemoglobin or anemia results in increased work on the heart and poor functioning of cells. The causes of anemia are multifactorial and may result from iron and other micronutrient deficiencies, inflammation derived from acute and chronic infections, inherited and acquired disorders affecting hemoglobin synthesis, and unexplained anemias. Anemia also may have poor outcomes and so is associated with increased morbidity and mortality, poor birth outcomes, decreased productivity, and more so with respect to decreased productivity related to iron deficiency anemia, as well as impaired cognitive and behavioral development in children. The World Health Organization estimates a prevalence of anemia of 42% in children and 40% in pregnant women. In the 2019, the Global Burden of Disease study indicated a global age standardized prevalence of 23,176 per 100,000 population. There has been a dearth of prevalence data with respect to anemia from Latin America and the Caribbean. The Global Nutrition Tracker, which relies on modeled data, indicates an anemia prevalence in non-pregnant women of approximately 30% in the Caribbean and 20% in Jamaica. Previous studies, which would have reported actual data in Jamaica, have primarily focused on high-risk groups, such as pregnant women, children, and the elderly, and we see the prevalence estimates as listed on this slide. And so the objective of this study is to estimate the prevalence of anemia in Jamaicans aged 15 years and older, and as a sub-objective, to estimate the prevalence of depleted iron stores. The Jamaica Health and Lifestyle Survey, from which this data was derived, was a cross-sectional nationally representative survey conducted in 2016 to 2017. 2,807 participants, and we heard this in the previous presentation, were randomly selected from enumeration district clusters, and of these, 1,331, or 41%, provided blood samples from which our prevalence estimates were derived. Statistical analysis was conducted using Stata 16, and the analysis yielded weighted population estimates for proportions with variance accounting for survey design. With respect to the definitions, anemia was defined as a hemoglobin level less than 13 grams per deciliter in males and less than 12 grams per deciliter in females. And this is taken from WHO criteria. The WHO criteria were also used in terms of the anemia severity classification, with severe anemia being classified or indicated as hemoglobin level less than 8 grams per deciliter in both sexes. The definition for depleted iron stores is a serum ferritin level of less than 15 micrograms per mil in both sexes. And to our results, mean hemoglobin levels were 14.8 grams per deciliter for males and 12.6 grams per deciliter in females. With respect to anemia prevalence, the overall prevalence of anemia was 17.6%, but when disaggregated by sex, we see anemia prevalence of 9.5% in males and 25% in females. The majority of anemia was mild in terms of the proportion. However, we want to also indicate that 9.6% of females had moderate anemia, and this was also indicated in terms of 5.3% of the total population. When we disaggregate anemia by age, we see that women of reproductive age had higher proportions with respect to anemia prevalence. Also in terms of the women less than 60 years of age. In contrast, men who were greater than 60 years had higher prevalence estimates than their younger counterparts. We now move to depleted iron stores, and the prevalence of depleted iron stores was 9.9% overall, 17.8% in females and 1.9% for males. When we disaggregate the prevalence of depleted iron stores by age group, again, we see that women of reproductive age had higher prevalence estimates. The World Health Organization has established threshold levels for public health significance with anemia prevalence of 20 to 39% designated as moderate public health concern, and estimates of greater than or equal to 40% being classified as severe, a severe public health problem. Based on the prevalence estimates presented today, the anemia prevalence in females and for older men would be classified as a moderate public health concern in these populations. So in summary, approximately 1 in 10 Jamaicans and 1 in 10 Jamaican males and 1 in 4 females aged 15 years and older were anemic. Approximately 1 in 10 women had moderate to severe anemia. 1 in 10 Jamaicans had depleted iron stores. 20% of elderly men and 17% of elderly women were anemic. This is of concern as anemia is an independent risk factor for mortality and is associated with negative health outcomes in this population. And already indicated, the prevalence of anemia in women of reproductive age and elderly men was greater than or equal to 20%, indicating moderate public health significance as defined by the World Health Organization. As with any research study, there are limitations, some of which are that anemia was not assessed in high-risk groups, such as pregnant women or children. The causes of anemia were not fully assessed, and the determination of iron deficiency did not account for inflammation. However, this data does provide important baseline information for tracking global targets to be attained by 2025. The particular target concerning anemia is a 50% reduction in anemia in women of reproductive age by 2025. Therefore, follow-up assessments in this age group would be needed, as well as assessments in the total population and high-risk groups, such as pregnant women. We also recognize that further delineation of the causes of anemia would be required in order to target public health interventions. These are my references. Thank you.
Dr. Grant, thank you for your presentation. The floor is now open for questions for Dr. Novi Younger-Coleman and Dr. Andreen Grant. Do you have questions? Yes? Go ahead, please.
Thank you for your presentation. It has been very interesting, very exciting. Anemia in elderly and then in the younger age group and the different population. My question, therefore, will go to both presenters, Dr. Younger-Coleman and Dr. Grant. Thank you very much for excellent presentation. So how do we correct or modify these findings in the very group that we have discussed? How are we able to promote a better health for the elderly and for the group that Dr. Grant spoke about, the age 15 reproductive age group? How are we able, going forward, to promote healthy lifestyle? How can they get more iron intake? Are we going to plant more callaloo? Are we going to put callaloo in every drink, in every food? What do we do? Thank you.
Am I being heard? Yes. Right. Well, I might not be the best person to answer that question because I'm not a nutritionist, but I'd like to piggyback on Dr. Khan's presentation because here is where maybe some of our health professionals could come in with, nutritional counseling Some of these people go to the doctor for other reasons. So maybe the health centers can take advantage of providing, information, whether as they wait in the rooms and so on, to see the doctor. That kind of information can be provided. Maybe there's need to query it some more, but certainly additional work is needed in terms of studying, as Dr. Grant suggested, what really is driving it, because I think there are different types of anemia, different things drive it, so you'd have to identify what the real drivers are. Some of the elderly are being managed, they're being fed by other people, so there's so many factors that would need to be taken into consideration.
Thank you.
Can I be heard? Can you hear me? So just to follow on what Dr. Younger-Coleman just mentioned a while ago, there are different causes of anemia. So it could be as a result of micronutrient deficiencies. It could be with respect to inflammation. And so especially in the elderly population, inflammation may be a result of either an acute condition or a chronic disease. And so because a high proportion of the elderly would have a chronic condition potentially, then it's important to know what the cause of anemia is. With respect to recommendations for women of reproductive age, the World Health Organization actually recommends folic acid supplementation in women of reproductive age where the prevalence estimate is greater than 20%. So the question we can ask for Jamaica, since our prevalence is greater than 20%, will we be recommending folic acid supplementation for that age group?
Thank you.
Okay, we're able to take one final question. Is there another one? Okay. Go ahead, please.
Okay, this is from Robin Stevenson for Dr. Grant. Excellent presentation. Given this was a national survey, are there any plans to examine the impact of national nutritional interventions, policy, and otherwise? I am thinking of our long-term efforts with antenatal clients.
Well, I think the nutrition unit would probably be the more appropriate representative to answer that question in terms of what the interventions would be with respect to anemia. Perhaps Mr. Christie could mention the question again so that the nutrition unit would be able to respond to it.
Given that this was a national survey, are there any plans to examine the impact of national nutritional interventions, policy and otherwise? You were saying that?
Okay, with regard to, from a nutritional point of view, I think that one of the things we, based off Dr. Grant's presentation, is that we would have to look at interventions. The folic acid intervention is a pretty good one, and it is fairly cheap, and we do have folic acid already in the health centers, so I think we could take it from that angle. The challenge with what was presented, as Dr. Grant said, is that you have different types of anemia, and the study did not really tease it out for you to definitively say, well, it is this type or the other type. But definitely folic acid management from that point of view would be fairly easy for the primary health care system.
Okay, thank you.
Okay, we have a comment from Professor Ferguson.
So just commenting on the possible intervention. So from the study Dr. Grant presented, she also looked at ferritin, which is a measure of iron stores. So it shows that there is some amount of iron deficiency. From previous studies, folic acid deficiency has not been a major contribution to anemia within our setting, but certainly we would want to look at that and probably make... Should I start over? All right, yes. So just to say that from the study Dr. Grant presented, she also looked at ferritin, which is a measure of iron stores, and therefore an indicator of iron deficiency. So it would suggest that iron deficiency is a contributing factor, but of course we would need to measure iron levels. What I think definitely we should be recommending that more screening for anemia be done in among women. So if 25% of the population is affected, then certainly there is some justification for screening, and interventions are available which are fairly simple in terms of iron replacement, etc. So I think those interventions can be looked at. Folic acid may be an option, but previous studies have suggested that folic acid deficiency may be relatively low. So it's probably more iron than folic acid, and we also should think about the frequency of the hemoglobinopathies, so sickle cell disease and so on, which may be a contributing factor that may be undiagnosed. And also things like alpha thalassemia traits, etc. So a lot more work to be done, but this is an indicator that we do have something that requires further study and important interventions. Thank you.
Okay, thank you very much. As Dr. Dawson pointed out, that supplements right, Dr. Dawson, is that better? All right, so Dr. Dawson pointed out that supplements are distributed to pregnant women in our health centers. However, more work needs to be done as to the actual uptake. So is it a case that the women are receiving the supplements, but they are not actually taking the supplements? So in terms of monitoring, we have to strengthen our surveillance system so that we are better able to monitor the effectiveness of the programs. Okay, I want to thank the participants, and I would also like to thank the presenters for the effort they have made in preparing the presentation and facilitating the presentations today. Indeed, the presentations were excellent, and the information is very useful and will definitely make an impact in the development of programs and plans for the future to combat NCDs. All right, so let us again thank them.
Good afternoon, Mrs. Turnipate. On behalf of the Secretariat, we'd like to present you with this token for your such well-done moderation of this session, and thanks to the presenters.
Okay, thank you very much. Okay, it's nice to be given a gift, unexpected, and I would like to thank you so much. Sometimes it's these little unexpected things that actually make our day, right, and our week, and this will definitely make my week. So thank you very much. All right, so up next we'll have an electronic presentation on the posters that have been selected for presentation at this, our 13th National Health Research Conference.
what we are spending to do the renovation.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. And the options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
We have not compromised on one service, one era of service that we are doing before the hospital was closed. We would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area. When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
The collapse of the Cornwall Regional Hospital posed a challenge to public health that I don't think we have seen post-independence. We engaged in a technical assessment to determine the value of what existed despite the challenges that were there, and it was determined that the building was sound. What we needed to do was to correct the air quality issues at the institution. You had to continue to use the building even with the challenges that you faced and the risks that were involved in that process of air quality issues, while transitioning and creating additional infrastructure around that main building to continue the services that were essential to saving lives. I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. Cornwall will one day become the best hospital in the West and probably one of the best in the Caribbean based on the work that is being done now.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. I will be elated, not just for me or for the ministry, but for the people who use the facility, doctors and the nurses who have put up with all the challenges over time, the patients who use the facility who have understood the nature of the inconveniences and why this is the case.
What will that moment of seeing that project to completion and walking into a new building feel like for you?
Well, you know, for me, it is likely to be, it will be a very fulfilling moment, without a doubt. I'll be extremely satisfied. It could be an emotional moment because we have seen the lows, we have seen the disappointments, we have seen the frustration, and to see now the success of a fully restored building will create joy and maybe even tears for some people. And for me personally, I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility who have understood the nature of the inconveniences and why this is the case. You know, I look forward to that day, and I will celebrate on behalf of all who will benefit from the restoration, and indeed take those lessons. In fact, I've asked for a case write-up of the Cornwall experience, because I think the lessons to be learned should be transmitted to all across the public health system to avoid any other institution from having the same fate. So in a sense, Cornwall Regional Hospital should be a teaching moment for us, and that's one of the major objectives that I would have in terms of moving the process forward.
Hello, Jamaica. I'm Dion Jax-Miller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen. Don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness.
Cornwall Regional Hospital was built in 1974. It was a gift of the Canadian government. They did all the technical work and provided the resources.
Thank you for taking the time to view the Ministry of Health and Wellness's National Health Research Conference webpage. My name is Hector Borras, and I am a Monitoring and Evaluation Officer with the Ministry, with my main duties being the application of Geographic Information System in health. I have been a member of the NHRC's Secretariat since its inception, taking on different roles throughout the years as needed. The conference is a platform for meaningful research. It has become a staple on the annual research calendar, being staged at a hotel conference room accommodating less than 100 attendees in its inaugural year to now possibly outgrowing, arguably, the largest conference facility in Jamaica, the National Conference Center. It's home for the past several years that has a room that can accommodate upwards of 1,000 persons. Being a Secretariat member, I look forward to not only a successful staging of the NHRC each year, but I also look forward in great anticipation to the oral and poster presentations and interacting and seeing the interaction with presenters, special guests, the judges, and all the other attendees. I think the level of networking that takes place cannot be understated. In terms of memorable moments, for me there are quite a few, but the two I would readily mention are: 1, the year the NHRC moved into the 1,000-seater conference room, and 2, celebrating 10 years in 2019 and having our largest submission of abstracts. COVID-19 has forced us to embrace technology much quicker than we anticipated.
th Annual Conference of the Ministry of Health and Wellness, Jamaica. Ladies and gentlemen, it has been 12 remarkable years bearing thought-provoking themes and watching think tanks delivering scholarly pieces that has been used as sound evidentiary decision-making of our strategic plans, policies, programs, projects, inter alia. I, Tasmoy Crawford, Director of Monitoring, Evaluation and Research at the National Family Planning Board, I'm truly honored to be a part of this remarkable and august journey over the years, wearing various hats as required of me by the conference secretariat heads. This is one of the most rewarding and intellectually stimulating events, and so I say congratulations, thank you, and hearty welcome.
Good day. My name is Kara Fletcher and I'm an orthopedic surgeon at the St. Anne's Bay Regional Hospital. I'd like to thank the National Health Research Conference for allowing me to talk about this award that I received in 2018, the most impactful presentation, and the presentation's title was Motorcycle Injury Seen at the St. Anne's Bay Regional Hospital. The journey began at the JIS studio, where I was able to speak about winning the award as well as the contents of the research. This award was subsequently published in the two major newspapers in the island, the Jamaica Observer and the Gleaner. This afforded readers of both traditional and social media a chance to read both about the award as well as the contents of the presentation. Now, this here represents an award that I won at the St. Anne's Bay Regional Hospital as a result of this research. And I'll just briefly read it. Certificate of Commendation to Dr. Kara Fletcher in recognition of the research you have done in relation to the injuries sustained by motorcyclists and associated risk. Your research has attracted international attention and promoted the St. Anne's Bay Regional Hospital as an authentic research facility. Two major publications have resulted from this research. The first one, Predictors of Hospitalization and Need for Surgical Intervention in the prestigious journal, which is an affiliate of the British Medical Journal. And the second journal is the International Journal of Injury Control and Safety Promotion, That publication spoke about helmet compliance and the incidence of insurance as well as registration. Now, this has led me to being a part of the NRSC, the National Road Safety Council, and I have had the opportunity to meet with both local and international researchers as well as discuss with the major stakeholders in the island with regards to road safety. So, where does the journey end? Hopefully not here, because the last thing that I desperately would like to do is affect legislative change, and hopefully that will be the end of the journey with regards to motorcycle safety. Thank you very much. Thanks for your attention.
Hello, everyone. It was Zara Neely Hudson who said, "Research is formalized curiosity. It is poking and prying with a purpose." My name is Karen Nelson, and I am the Deputy Chief Nursing Officer in the Ministry of Health and Wellness. One who is extremely passionate about research ever since I entered the nursing profession. Let me extend profound gratitude to the administrators of the National Health Research Committee for the opportunity to be
We were given a mandate to provide oversight of the redevelopment of the Conrad Regional Hospital. The oversight committee visited the site and inspected the building, and we all concluded that it was a worthwhile building to renovate. To construct a new building would cost 10 times as much of what we are spending to do the renovation.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. And the options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them were identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
We have not compromised on one service, one area of service that we are doing before the hospital was closed. We would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area. When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
The collapse of the Cornwall Regional Hospital posed a challenge to public health that I don't think we have seen post-independence. We engaged in a technical assessment to determine the value of what existed despite the challenges that were there, and it was determined that the building was sound. What we needed to do was to correct the air quality issues at the institution. You had to continue to use the building even with the challenges that you faced and the risks that were involved in that process of air quality issues, while transitioning and creating additional infrastructure around that main building to continue the services that were essential to saving lives. I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. Cornwall will one day become the best hospital in the West and probably one of the best in the Caribbean based on the work that is being done now.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility who have understood the nature of the inconveniences and why this is the case.
What will that moment of seeing that project to completion and walking into a new building feel like for you?
Well, you know, for me, it is likely to be, it will be a very fulfilling moment, without a doubt. I'll be extremely satisfied. It could be an emotional moment because we've seen the lows, we've seen the disappointments, we've seen the frustration, and to see now the success of a fully restored building will create joy and maybe even tears for some people. And for me personally, I will be elated, not just for me or for the ministry, but for the people who use the facility. doctors and the nurses who have put up with all the challenges over time, the patients who use the facility, who have understood the nature of the inconveniences and why this is the case. I look forward to that day, and I will celebrate on behalf of all who will benefit from the restoration, and indeed take those lessons. In fact, I've asked for a case write-up of the Cornwall experience, because I think the lessons to be learned should be transmitted to all across the public health system to avoid any other institution from having the same fate. So in a sense, Cornwall Regional Hospital should be a teaching moment for us. And that's one of the major objectives that I would have in terms of moving the process forward.
Hello, Jamaica. I'm Dion Jax-Miller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness.
Cornwall Regional Hospital was built in 1974. It was a gift of the Canadian government. They did all the technical work and provided the resources to build the facility.
Over the years, clearly, there was poor maintenance of the building, but also the building was modified by non-experts. People were constructing offices in the corridor. What that does is to interfere with the airflow and the ventilation. There was water seeping through the roof, it was leaking, but also seeping through the walls, and there were the plumbing fixtures and so on.
As long as you have moisture building up in concrete, in wood, and so on, you're going to have some conditions that are suitable for the growth of mold. To be able to find out the extent of that problem, basically the entire building had to be gutted.
The collapse of the Cornwall Regional Hospital posed a challenge to public health that I don't think we have seen post-independence.
Closing this hospital would not be an option. It would be like closing KPH.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. The options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
In 2017, when it was deemed that staff were primarily affected by the air quality issues, we realized that we had to relocate on a phase basis and not en bloc.
We are not on the main building, we are all across the campus. We are down the road, we are over West Jamaica Conference, and we are up at Falmouth. Movement on the campus mean you have to, serving patient mean you have to move up to Falmouth, you have to move down to Barnet Clinic, you have to move across the campus. And sometimes it is very hot, sometimes it's raining.
We have not compromised on one service, one area of service that we are doing before the hospital was closed. We would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them were identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
It was a worthwhile building to renovate. To construct a new building would cost 10 times as much. And when they're renovating a building, you get many surprises. And that is what has been happening at Cornwall Regional. So you demolish a wall or to find problems which were not planned for.
We understood that there are delays. We knew that persons were disgruntled. Some persons, of course, left. But some of us decided that we're going to have to stick through this and get through it.
When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
What I can assure members of the public is that we are doing all that is necessary in terms of identifying what are required, bit of resources, bit of management system and so on. And certainly these will be incorporated in our budget in going forward.
So we're building the capacity from now. We're looking to get all the expertise we need, that going forward, once the hospital is built, the whole issue of maintenance will not go back to where it was.
What will that moment of seeing that project to completion and walking into a new building feel like for you?
I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility, who have understood the nature of the inconveniences and why this is the case. You know, I look forward to that day, and I will celebrate on behalf of all who will benefit from the restoration, and indeed take those lessons, because I think the lessons to be learned should be transmitted to all across the public health system to avoid any other institution from having the same fate. So in a sense, Cornwall Regional Hospital should be a teaching moment for us. And that's one of the major objectives that I would have in terms of moving the process forward. Ladies and gentlemen, I wish to congratulate the Rotary Club of Downtown Kingston for hosting this webinar on World Diabetes Day. As we turn the spotlight on diabetes this November, we must acknowledge the scale of the problem of NCDs and redouble our efforts to solve it, drawing on all our resources, including our nurses, who are essential not only as healthcare providers, but also as professionals to whom we can rely for the promotion of self-care management among patients. Our nurses also play a role in helping to safeguard the mental health of their diabetic patients, from identifying emergent psychosocial to making the appropriate interventions to support their patients. This year's theme for World Diabetes Day, Diabetes Nurses Make a Difference, therefore is most appropriate. And in a year designated as the Year of the Nurse, this World Diabetes Day, we encourage stakeholders, from persons living with diabetes to their family and friends and others involved in their care management, to join our nurses in the effort to ensure the best possible health outcomes for persons with diabetes, and to, as far as possible, engage in behaviors to reduce the incidence of diabetes and other NCDs. Those behaviors include increased physical activity, a healthy diet, routine health checks, and strict medication adherence. All the best, and thank you.
Hello, I'm Dr. Shin Young-soo, and Regional Director for the Western Pacific World Health Organization. Today, on the World Health Day, I would like to ask you, how safe is your food? Does your country's food safety system protect you and your loved ones? Does it follow international best practice?
Harmful bacteria, viruses, parasites, and chemicals can contaminate food. Every year, millions of people in Asia and the Pacific are affected by diseases that are caused by unsafe food. Unsafe food causes more than 200 diseases, including acute diarrhea, cancer, kidney failure, brain disorders, and chronic malnutrition. Diarrhea is the most common symptom of food and waterborne illnesses, causing some 2 million deaths a year. The risk of unsafe food crossing borders is greater than ever. Trade in food and livestock products in Asia has increased threefold in the past 20 years. Contaminated food can transport disease halfway around the world in a few days. Food safety is a shared responsibility. Countries must work together to prevent foodborne disease outbreaks. Because food safety assurance is only as strong as the weakest link in the food chain. Food safety incidents also have economic consequences. Millions of dollars are lost every year due to food contamination. Consumers lose confidence in the food and stop buying it. Businesses close, people lose their jobs, and exports decline. Food safety must be a priority, from farm to plate. Governments must take responsibility and ensure that all foods comply with minimal food safety and quality requirements. Otherwise, the health and economic consequences may be serious. WHO helps member states build capacity to prevent, detect, and respond to foodborne disease outbreaks. This includes building national core capacities as required under the international health regulations and facilitating rapid exchange of information through the International Food Safety Authorities Network, managed by FAO and WHO. Make safe, healthy food a priority. Take responsibility to ensure food safety. This will help your country maintain good health and achieve economic prosperity.
Hello, I'm Dr. Shin Young-soo, and Regional Director for the Western Pacific World Health Organization. Today, on the World Health Day, I would like to ask you, how safe is your food? Does your country's food safety system protect you and your loved ones? Does it follow international best practice?
Harmful bacteria, viruses, parasites, and chemicals can contaminate food. Every year, millions of people in Asia and the Pacific are affected by diseases that are caused by unsafe food. Unsafe food causes more than 200 diseases, including acute diarrhea, cancer, kidney failure, brain disorders, and chronic malnutrition. Diarrhea is the most common symptom of food and waterborne illnesses, causing some 2 million deaths a year. The risk of unsafe food crossing borders is greater than ever. Trade in food and livestock products in Asia has increased threefold in the past 20 years. Contaminated food can transport disease halfway around the world in a few days. Food safety is a shared responsibility. Countries must work together to prevent foodborne disease outbreaks. Because food safety assurance is only as strong as the weakest link in the food chain. Food safety incidents also have economic consequences. Millions of dollars are lost every year due to food contamination. Consumers lose confidence in the food and stop buying it. Businesses close, people lose their jobs, and exports decline. Food safety must be a priority, from farm to plate. Governments must take responsibility and ensure that all foods comply with minimal food safety and quality requirements. Otherwise, the health and economic consequences may be serious. WHO helps member states build capacity to prevent, detect, and respond to foodborne disease outbreaks. This includes building national core capacities as required under the international health regulations and facilitating rapid exchange of information through the International Food Safety Authorities Network, managed by FAO and WHO. Make safe, healthy food a priority. Take responsibility to ensure food safety. This will help your country maintain good health and achieve economic prosperity.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my home. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give their children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
What happened, Aiden? My mama told me I need to come off the tablet. Yes, you should. We need physical activity. Well, that's what the adults say. Adults, I tell you. Seriously though, with physical activity, we will get better grades, better heart health, and improve the bone health. Oh, I heard it will improve memory and overall mood. Yes, it will maintain our weight and lowers the risk for depression. Do you know what will lower your risk of depression? What?
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
We're gonna get funky, 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 funky. Everybody clap your hands. Clap, 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 clap your hands. Clap, 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 clap your hands. All right, now, we're gonna do the basic step. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha, real smooth. Turn it out. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha now, y'all. Now it's time to get funky. To the right now. To the left. Take it back now, y'all. One hop this time. One hop this time. Right foot, 2 stumps. Left foot, 2 stumps. Slide to the left. Slide to the right. Crisscross. Crisscross. Cha-cha, real smooth. Let's go to work. To the left. Take it back now, y'all. 2 hops this time. 2 hops this time. Right foot, 2 stumps. Left foot, 2 stumps. Hands on your knees, hands on your knees. Get funky with it. Oh, yeah. Come on. Cha-cha now, y'all. Turn it out. To the left. Take it back now, y'all. 5 hops this time. Right foot, let's stomp. Left foot, let's stomp. Right foot again. Left foot again. Right foot, let's stomp.
Reduce your risk of viral illnesses like the flu and coronavirus. Wash your hands frequently with soap and water. Cover your nose and mouth when coughing with a tissue and dispose of it. Avoid close contact with anyone with the cold or flu-like symptoms. If you think you've been exposed to COVID-19, stay home. Self-isolate immediately and call 888-1-LOVE. That's 888-663-5683. A message from the Ministry of Health and Wellness.
provision of services to public patients living with diabetes and hypertension through the engagement of private general practitioners is a welcomed initiative, and the Western Regional Health Authority stands firm in its commitment to healthy families living in healthy communities. This value-added service will increase and improve access to care for persons living with diabetes and hypertension.
We have partnered with the Association of General Practitioners of Jamaica as well as the Ministry of Health and Wellness to engage in a public-private partnership to provide access or to provide care for individuals with diabetes and hypertension in this post-COVID era. What it means is that you can go to a private doctor to have your care and be provided with the same level of care as you would receive if it is that you actually went to a public health center or public health facility.
SARA is the largest of the 4 regional health authorities with responsibility for providing health care to almost half the Jamaican population. And as such, we are endorsing the private-public partnership initiative of the Ministry of Health and Wellness regarding non-communicable diseases.
The Northeast Regional Health Authority fully endorses the public-private partnership between the Ministry of Health and Wellness and private physicians as we address patient care in the health system. All our diabetic and hypertensive patients will have the opportunity to be treated through private physicians as we move to enhance patient care while we go through this COVID-19 pandemic.
The Southern Regional Health Authority endorses the public-private partnership between the Ministry of Health and Wellness and private practitioners. At this time, as we respond to the COVID pandemic, it's important that the health of the region is maintained, and so chronic disease patients continue to attend clinic and to maintain their health. While this is happening, it's important that we appropriately respond to the pandemic at this time. So with this partnership, it will allow us to meet our mandates to ensure that at the end of the pandemic, we would have appropriately responded and our persons are able to maintain and be the best version of themselves.
Come pre this you, don't pre that, let me tell you about the body and some physical facts. Come pre this you, don't pre that, let me tell you about the body and some physical facts. Physical activity defined as bodily movement. You know it beneficial to every student. Chin up, push up, jogging, sit up, feeling lazy, better get up. Physical activity help your mood and memory, make you remember anything, cause it boosts dopamine and serotonin. Target attention, focus, regulate moods. Come learn something, yeah man, listen young youth. Physical activity, healthier weight, go and exercise, students hold the faith. The more you do, the more calorie your body use. Calorie deficit, calorie get reduced. Exercise build your bone and make it more dense. A facts we attack, ladies and gents, physical activity is of the essence. Needed like full stop in any sentence. Come free this you, don't free that, let me tell you about the body and some physical facts. Come free this you, don't free that, let me tell you about the body and some physical facts.
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
One, two, three, two more.
Yes, good afternoon. Everybody hearing me? And even seeing me, which is more important. Thank God the podium is not a few inches higher, taller. Okay, I'm going to actually let you see my nose, which I tell children these days is a private part. It's my pleasure to moderate this session. This is the second scientific session, and we're dealing with non-communicable diseases and mental health. And the first session is a hard act to follow, so guys, we have to do as well. We're going to be great with time management, and I know the content will be very interesting. So we have 4 speakers who are all going to end up sitting here. We will first hear from Dr. Nikisha Golson de Pass, who's a clinician at CHAIRS, the Center for HIV/AIDS Research, Education and Services Clinic at the University Hospital of the West Indies, where she predominantly treats patients with HIV and AIDS, but she is also a voluntary research assistant at the Epidemiology Research Unit at the Caribbean Institute for Health Research. She will be followed by Ms. Kerry-Ann Facey, who is a project manager at CARE for the Caribbean COVID-19 Metabolic Health Study. And this is a 3-country study examining the impact of the pandemic on lifestyle practices and metabolic health of persons living with NCDs. She has a BSc in biochemistry from UWI and an is an MSc epidemiology candidate. After these 2, we will have some questions and answers, and then we will go on to Ms. Brown, who is a doctoral student within the Department of Sociology, Psychology, and Social Work at the UWI, MONA. She's the Secretariat head of the Jamaica Statistical Society and also co-author of the impact of COVID-19 on NGO beneficiaries in the Eastern Caribbean. And then finally, we will wrap up with Dr. Jacqueline Duncan, who is an internal medicine, occupational medicine physician, and a public health specialist. She's a senior lecturer and program coordinator for the Doctor of Public Health program at the Department of Community Health and Psychiatry. Her interests include monitoring and evaluation and research on various chronic diseases, as well as health system strengthening through operational research. So this afternoon in this session, we'll hear about urine sodium to potassium ratio, screen time, early childhood body weight, and rheumatic fever prevention and control. So we look forward to all of these, and I invite our first speaker, Dr. Nikisha Golson de Pass, to come.
Good afternoon, everyone. Thank you, Professor Knight Madden, for your kind words of introduction. Thanks to the Ministry of Health and Wellness and the National Health Research Conference for inviting us to present on our study, urine sodium to potassium ratio and its association with socio-demographic and clinical factors among Jamaican adults. This study was undertaken by the Caribbean Institute of Health Research in partnership with the Ministry of Health and Wellness. I want to thank the team of researchers depicted on this slide who worked assiduously in preparing this project and for giving me the opportunity to present on behalf of our team today. Salt, or sodium chloride, is a major component of the food supply in most countries. It is commonly used to flavor food or as a food preservative. Humans need about 500 milligrams of sodium each day to carry out normal metabolic functions as well as nerve conduction. The main source of sodium in the diet is table salt, with other sources being MSG and baking soda. Most people consume about 9 to 12 grams of salt per day, which is approximately twice the recommended 5 grams per day by the World Health Organization. High salt intake has multiple adverse health outcomes, including but not limited to high blood pressure and heart failure, stroke, chronic kidney disease, stomach cancer, osteoporosis, and obesity, which cumulatively account for 3 million deaths per year globally. Low potassium intake is associated with several non-communicable diseases. An increased potassium intake may reduce blood pressure, decrease the risk of cardiovascular disease, and mitigate the negative consequences of high sodium consumption. The WHO recommends an increase in potassium intake from food to reduce these risks and suggests an intake of at least 3,510 milligrams per day for adults. Studies have shown that high sodium and lower potassium intakes were associated with a higher cardiovascular risk in a dose-response manner. combined moderate sodium intake with high potassium intake was found to be associated with the lowest risk of mortality and cardiovascular events. Other studies suggested that the ratio of sodium to potassium intake, with a sodium to potassium ratio being less than 1, may be a better marker of cardiovascular risk factors as opposed to looking at each element by itself. The objectives of our study was to estimate the prevalence of high urine sodium to potassium ratio among Jamaican adults and to evaluate for associations between the sodium-potassium ratio and socio-demographic and clinical characteristics. We analyzed 1,002 spot urine sodium samples and estimated the 24-hour dietary sodium and potassium consumption using the PAHO formula illustrated on this slide. We estimated the sodium to potassium ratio by dividing the 24-hour urine sodium by potassium. Estimated means for 24-hour urine sodium and potassium and proportions with high sodium to potassium ratio was defined as being greater than 1. We assessed for associations between the sodium to potassium ratio and age, sex, socioeconomic status, and clinical characteristics. Linear regression models were used to evaluate associations in bivariate and multivariate models. Variables for final models were selected using backward stepwise regression with separate models created for men and women, as there was evidence for sex interaction for some associations. Analyses were weighted to account for survey design, and multiple imputation was used to account for missing data. Our study included 363 males and 639 females with a mean age of approximately 48.5 years with no sex differences. The mean spot urine sodium concentration was 2,976 milligrams per liter and was found to be higher in men compared to women. The mean spot urine potassium concentration was 2,146 milligrams per liter and was not significantly different between the genders. So when we looked at the mean values for characteristics of participants included in our analyses, we found that BMI, systolic blood pressure, and fasting blood glucose were all statistically significant. The mean sodium to potassium ratio was found to be greater than 2 in both males and females. The prevalence of a high sodium to potassium ratio was found to be 76% in males and 71% in females, with high sodium excretion being 73% and 60% in males and females respectively. We found low potassium excretions were greater in females at 92%, and 85% of men had a low potassium excretion. So when we did our multivariable analyses, sex-specific models were used for men and women. The variables included in the models were not the same because of our stepwise selection process. As such, we ended up with separate models for men and women. So this model here is representing what we found for men, and we found that age, moderate to high physical activity, and greater than 12 household possessions were inversely associated with a high sodium to potassium ratio, while education up to the secondary level was found to be positively associated with a high sodium to potassium ratio. For women, we found that age, pre-hypertension, hypertension, overweight, a reduced GFR, and post-secondary education were inversely associated to the sodium-potassium ratio. The sodium-potassium ratio was elevated in both males and females with no significant differences between the genders. Among men, sodium-potassium ratio was inversely associated with age, moderate and high physical activity, and high household possessions, while secondary education was positively associated with the sodium-potassium ratio. Among women, age, pre-hypertension, hypertension, overweight, a reduced GFR, and post-secondary education were inversely associated with the sodium-to-potassium ratio. Our study was limited by the fact that the sodium and potassium levels were measured using spot urine samples rather than the preferred 24-hour urine samples. Spot urine samples were only available for a subset of the survey participants, and some participants had missing data. The cross-sectional design of our study also limited our ability to make causal inferences. To conclude, most Jamaican adults have diets high in sodium and low in potassium, which results in a high sodium to potassium ratio. While associated factors differed in men and women, high socioeconomic status appears to be associated with healthier diets. We recommend urgent public health interventions are needed to reduce salt consumption and increase potassium intake to address the burden of hypertension and cardiovascular disease currently being experienced in our population. Thank you.
Well done, and in good time as well. So we will definitely have time for questions, so please be working on that. I neglected to introduce myself. I'm Professor Jennifer Knight Madden from the Sickle Cell Unit at the Caribbean Institute for Health Research, who works quite a bit with the Ministry of Health, which is my joy, because that is how we impact health across the island. So next is Miss Carrie-Ann Facey, and she'll be talking about the impact of screen time activities on physical activity levels in Jamaican adolescents aged 13 to 17 years old. If you have children in that age group like me, feel free to say ouch. And isn't it wonderful to see these young people? The future of research in Jamaica is assured by teaching people to carry it on. So very happy to see them. Please come, Ms. Facey.
Good afternoon, everyone. Thank you, Professor Knight Madden, for your introduction. Thank you to the organizers for the opportunity to present at this conference, and also to the collaborators who listed here on my first slide for their contribution to this body of work. Today, I will be speaking on the impact of screen time activities on physical activity levels in Jamaican adolescents aged 13 to 17 years old. But before the presentation of my findings, I would first like to describe some key terminologies. The first concept is physical activity, and this is defined as any bodily movement done by skeletal muscles which requires energy expenditure. There are 5 domains of physical activity, and they are recreational, transport, sporting, chores, and work. In 2010, the World Health Organization recommended that adolescents do 60 minutes of moderate to vigorous physical activity, that's MVPA, per day, as it provides fundamental health benefits. There was a global study, which was published in 2019, which revealed that 80% of school-going adolescents did not meet the WHO recommendation. And when we look at a local study, which is the 2017 Jamaican Global School-Based Survey, it found that only 23.2% of students were engaging in 60 minutes of MVPA per day. The other concept is screen time, and this is any activity done in front of a screen. For this, the WHO has recommended no more than 2 hours per day for screen time for children and adolescents. And the 2017 Jamaican Global School Survey found that 56.4% of adolescents engaged in 3 or more hours of sedentary behavior outside of school hours, and this includes screen time activities and talking to friends. There was a 2019 study by Sanders which stated that not all screen time is the same. And in his study, he found that different screen time activities had different effects on adolescent behavior. Traditionally, when we look at screen time, it is usually grouped under one large umbrella. But with technological advances and the shift from watching TV to more time being spent scrolling on social media or playing computer games, it's important to examine the impact of different screen time categories on adolescent behavior. Therefore, he categorized screen time into 4 different groups. We have social, and we're talking about browsing Instagram,
passive, watching TV, interactive, playing video games, and educational, which is of course using the computer for schoolwork. For our study, we decided to investigate the relationship between screen time activities and meeting moderate to vigorous physical activity targets in Jamaican adolescents. This study hopes to provide some insight if interventions are to be developed to address the increase in obesity in Jamaican adolescents. And this study is also unique because it hasn't been done in the Jamaican context. In the next few slides, I will speak about our methods. And this was a cross-sectional study done between May 2019 to February 2020. The data forms part of the GDAR study, which is a multi-country study done in 4 low and middle income countries, and this report focused mainly on data collected in Jamaica. We recruited from 5 high schools in Kingston and St. Andrew, from low to high socioeconomic neighborhood settings, and this comprised of 2 all-girls schools, 2 co-ed schools, and 1 all-boys school. And we excluded students who had intellectual or physical disabilities and those living in institutions. For data collection, we used a modified version of the physical activity questionnaire, and this was piloted on a sample of Jamaican students who were not enrolled in the study. We collected information on daily hours spent in screen time activities, which formed our exposure variable, and information on daily minutes and intensity spent in recreational activities such as playing dandy shandy or private extracurricular activities such as participating in a community sports team. And these formed our outcome variables. Ethical approval for the study was obtained from the UE Mona Research Ethics Committee, and the Ministry of Health granted us approval to approach the selected schools. Parents signed consent forms, and students were guided through the assenting process. For statistical analysis, we used descriptive analysis to determine sex differences. Logistic regression models were used to assess the relationship between screen time and meeting MBPA targets, and a p-value of less than 0.05 was considered to be statistically significant. Now for our findings. Table 1 here shows us the characteristics of the study sample. And data were analyzed for 216 students. 57 boys made up 26% of the sample, and 159 girls made up 74% of the sample, and both had a mean age of 14 years. 60% of girls came from all-girls school, and 49% of boys came from an all-boys school. Looking at household socioeconomic status, 23% of boys were from a low SES household, and 33% of girls were from a low SES household. This slide shows us the median daily minutes spent in recreational and private extracurricular activity per day. 50% of girls reported a median of 42 minutes, and 50% of boys a median of 39 minutes. And for recreational activity, which was different, we had 50% of girls reporting a median of 12 minutes, and 50% of boys a median of 38 minutes. So there was some statistical significance difference here for recreational activity. In this slide, we are looking at the median daily hours spent in screen time activities. And for passive screen time, both boys and girls spent 5 hours, a median of 5 hours. And for social screen time, both boys and girls spent a median of 8 hours. However, when we look at interactive screen time, we see a difference where 50% of girls spent half an hour daily, and 50% of boys spent 4.5 hours daily. So for this table, we are looking at the odds of participating in private extracurricular activity, and there are no significant associations here. In the next slide is another logistic regression model, and it's showing the odds of participating in recreational activity. And we see that more time spent in interactive screen time increased the odds of participating in recreational activity. No other variables were significant. So to summarize our findings, there were no gender differences observed in time spent in passive screen time activities. However, both boys and girls exceeded WHO recommendation of 2 hours. Although boys and girls spent similar amount of time in private extracurricular activity, they did not meet the recommended levels of 60 minutes per day.
Thirdly, boys were more likely to engage in recreational activity than girls. And interactive screen time may have a positive relationship with recreational MVPA. We recommend that further studies be done to examine the impact of screen time on overall physical activity. That's taking into consideration all 5 domains of physical activity, and future studies should be done on a larger sample of males so as to accurately assess associations between screen time and physical activity. I'd like to say thank you to the funders, staff, and students from participating schools, and again to the organizers of this conference.
Thank you, Ms. Facey. All right, so we do have time for questions. So are there any questions in the room? Yes, ma'am, please go ahead.
Thank you. Thank you for your presentations, excellent and in good timing. I have questions for both presenters. I'll start with the last presenter. I discovered that from your presentation, most students were from high-income households. Is that true?
Hello? Yes.
So is it that because the parents are able to purchase the tools for them and they have the devices, so they have all the time to spend on these devices? Do you think that is the case?
Yes, that was one of the theories that we had, which resulted in them spending less time in recreational activity.
Okay, now, what do we do? Take away the tablets and the phones? What is your recommendation? Because it's a practical step. It's a finding. And most parents will say, oh, I'm at work, I'm busy, and the child, just let them go on. 8 hours? That's a lot.
Yes. So one of our recommendations is really for parents to try and impose limits. Another aspect that I didn't present on was we actually asked students if their parents had any limits on the amount of time they could spend watching TV, and we found that the majority of students said that no, there were no limits. So we can recommend, having limits and also encouraging playtime outside, excluding, when they're come home from school outside of school hours.
Okay, thank you. Because I was wondering that as a young person, what is your opinion? It's good for me to know what you think. So sending them out to play is important. Then the urine sodium to potassium ratio, yes. That was another excellent presentation. So what is the simple practical way can we modify the ratio for food consumption?
Okay, thank you for your question. So given the fact that typically as doctors, we tend to focus more on recommending that patients lower their sodium intake, we believe that with the information that we have garnered from this study, public education is important in letting people know that they should not necessarily focus only on lower sodium intake, but having a wider variety of healthy foods in the diet from which they may obtain more potassium. Because other studies have shown us that instead of looking at or trying to target lower sodium intake, a higher potassium intake tends to offset a high sodium consumption.
Thank you very much. So before you came, we had that discussion behind your back. So you answered well. Now, the foods that we need that had high potassium, for instance, the avocado.
Yes.
Okay.
Yes.
So what do you recommend? Could we crush avocado and give to them all the time?
No. No, all right. So it's very good that we live in a tropical country. There are a lot of coconut trees, avocados, and bananas are very high in sodium. Even chicken and fish. Sorry, potassium. My apologies. Fish and chicken is also high in potassium, but just widening the diet, eating more whole foods, less foods that are packaged, will typically increase your potassium intake.
Thank you.
Thank you.
Are there any online questions? Yes?
Okay, this is a question for Dr.
Not hearing you well.
This is a question for Dr. Golson. The past coconut water contains potassium with 1 or 2 glasses, which would be 250 to 500 milliliter per day, provide the required amount of potassium needed.
So that's an excellent question. Unfortunately, I do not have the answer to that question today because we didn't really focus on the mils of consumption, more the milligrams of the elements in whatever we're eating. And so I would have to research how many milligrams of potassium would be found in 2 glasses of coconut water to answer that question. But I'll definitely do that after the presentation today.
Okay, thank you. And the next question is, what about physical education classes? Would extending the practical aspect of this class increase their physical activity level to meet the recommended World Health Organization 60 minutes per day?
Well, one of the limitations, I would say, of the study is the fact that we didn't assess for all 5 domains of physical activity. So having physical activity in school wasn't really assessed for. But in order to properly say that students are, not meeting MVPA targets, we'd have to assess for all 5 domains. So what we really wanted to focus on in this study is choice physical activity, which is physical activity that students did in their free time. And our finding from that was that most of these students were probably spending more time in screen time than actually meeting physical activity targets at home outside of school. So looking at it in school would be another way to assess for meeting total physical activity targets.
Okay, thanks. And the last question is, when you have too much potassium in the body, how can it be dealt with and what are the consequences?
Okay, thank you for that question as well. Well, the average healthy human being, your kidneys are a major source of excretion of potassium from the body. So once there are no abnormalities in your kidney function, excess potassium would be excreted in your urine or via the alimentary tract or sweat. So it depends really on if the person has any issues with their kidneys, but for the regular average healthy Jamaican individual, you would be able to excrete excess potassium from the urine relatively simply.
Okay.
Wonderful. We're right on time.
One last question, Doc.
One more question?
Yes. Just Dr. Golden DePass. Thank you, ladies, for 2 great presentations. Dr. DePass, I was curious. I saw household possession as one of the factors that were analyzed. Why was this factor selected and how does it influence the behavior?
Okay, that's also an excellent question. So we looked at 2 ways of assessing for socioeconomic status, education level being one of them, and number of household items was another means of assessing for socioeconomic status. We found when we did our multivariable analyses that educational level differed between males and females with regards to it being associated or significantly associated with a high sodium to potassium ratio. So what we found was that the number of household possessions was a better indicator of socioeconomic status.
Thank you. It's always easy to do the talk. It's not always easy to answer the questions. So when you see them able to bat like that, you know that they actually know what the research is about. Give them a hand again for me. They're not wagonists. They're part of the work. Okay, so we have the next 2 coming up. So Miss Marsha Brown will come to talk to us about early childhood birth weight, NCDs in urban Jamaica, and then Dr. Duncan will come to talk to us about medical specialists and rheumatic fever prevention.
Good afternoon, everyone, and thank you, Minister of Health, for inviting me to present at the conference. Thank you so much, Professor Madden. I would like to wish everyone, just at the beginning of this presentation, a happy 8 billion mark for us as a world. Yesterday, we celebrated 8 billion persons being on the world. So let us give ourselves a round of applause. We are all planners and developers in this room. So I would like to say, wishing everyone, happy 8 billion mark. My presentation is titled Early Childhood Body Weight and Non-Communicable Disease Risk in Urban Jamaica. Actually, the presentation will take the following format. I will talk about the background and key terms. Then we'll focus on my research objective or aim, the methodology. The findings was broken down into certain sections as a sex pattern of overweight versus obese children, age patterns of overweight or obese children, age patterns of overweight or obese children for 2020 and 2021, the number of children that are at risk of being overweight, the population pyramid for 2037, and then I'll get into the conclusion and recommendations. So just to begin, globally in 2020, there were 39 million children under 5 years of age that were either overweight or obese. I bring this figure to you to show you that this is a level of social concern for us, the number of children that are classified as overweight or obese. In 2017 for Jamaica, approximately a third of the population, 13 to 17 years, were classified as overweight or obese. And also to note that childhood obesity is associated with hypertension, early onset of cardiovascular disease, and the increased likelihood of adolescent obesity. Both the WHO and UNDP estimate that Jamaica will spend approximately $77.1 billion between 2017 to 2032 on both diabetes and cardiovascular disease. So the situation is that we have to do preventative checks as well to lower the risk and likelihood of both hypertension and diabetes. Key terms for the study: obesity. Obesity was defined as having 3 standard deviations away from the normal BMI for both age and sex by WHO, while overweight was having between 2.1 to 3 standard deviations above normal BMI for age and sex by the WHO standard, and at risk is just having 1.1 to 2 standard deviations above the WHO normal BMI for age and sex. So what is the main aim of this study? The aim of this study is to examine age and sex patterns in early childhood and non-communicable disease risk due to body weight in urban Jamaica. The methodology states that the research used data from the monthly clinical summary reports for January 2019 to December 2021 on children 3 years of age and under, which was declassified into children 0 to 89 days, 3 to 11 months, 1 to 5 years of age, that were located in Kingston and St. Andrew. The study focused on children diagnosed overweight or obese. In addition, there was an analysis of the number of children at risk of being overweight over the study period. The statistical significance of the observed age-sex patterns were calculated using the Mann-Whitney-U and Crisker-Wallace tests. So now to the key findings. The first set of findings had to do with the sex pattern of children diagnosed overweight or obese between 2019 to 2021. So the Mann-Whitney-U test indicated that in 2019, there were more males than females who were diagnosed overweight or obese. And in addition, for 2020, we noticed that there was no difference between males and females for that year. However, there was an observable difference in 2021 between males and females being diagnosed overweight or obese. Regarding age patterns, for 2019, more children 3 to 11 months were diagnosed overweight or obese. Now, I did a comparative graph trying to show the difference between 2020 and 2021, noting that for 2020, the age that showed the highest likelihood of being diagnosed overweight or obese were children 3 to 11 months. However, in 2021, it moved to children 1 to 5 years of age. Sorry, 1 second. Sorry about that technicality. Okay. Number of children diagnosed at risk of being overweight between 2019 and 2021. So the at risk is they're actually not really overweight as yet. And we notice that there's a clear decline from 2019 to 2021. We can see here the impact of COVID coming in at the different interventions regarding healthy eating. And even though if you're looking at the line, the orange line represents 2020, even there are times when 2020 would rise up almost closer to 2019, it still would not be at the same baseline level. The year reporting the lowest number of risk of children the year reporting the lowest number of children at risk of being overweight was actually 2021. And we can see that from the start of 2021, there was some variation, but August being the lowest, and this may correspond to different restrictions that were put in place by policies. Now, the population period of Jamaica is just 15 years ahead of time, when Jamaica is actually at 3 million, estimated by UNDP. And the population that was studied, those that range from 0 to 5 years of age, would be in the 15 to 19 age group at the point in time of the population pyramid. It's important to know that the change of Jamaica's population pyramid, where the onset of the working class age group, which should be most vulnerable to diabetes and hypertension, they're getting into adulthood right now. They are the ones that are having the bulge, and they're the ones that are moving from our 0 to 5 population that we have just looked on in 2019 going up to 2021. Also to note that it is expected that in 2037, Jamaica will have like 79.4 years for life expectancy compared to 75.8 years now. That's calculating for both sexes. The challenge is that every single decade, a nation that is developing properly, we're supposed to be moving at like 3.6 years in gain. However, due to death or like non-communicable diseases, violence, and different things, Jamaica only advanced, is supposed to advance only 2.8 years. So I also did a age dependency ratio and found out that 51%, we're going to have a 51% age dependency ratio for Jamaica in 2037. And so therefore, the healthier our working age population is the more important it is to us for development. Conclusion. More males than females were diagnosed overweight or obese in 2019 and 2021. More children 3 to 11 months were diagnosed overweight or obese in 2019 and 2020. However, in 2021, more children 1 to 5 years of age than other ages were diagnosed overweight or obese. There is a steady decline in the number of children at risk of being overweight or diagnosed overweight between 2019 to 2021. And then finally, due to non-communicable diseases and other leading causes of death, Jamaica will only gain, as I said before, 3.6 years in life expectancy over the next 15 years. My recommendation, an extension of campaigns such as Protect Our Children's Health to include community support groups for both healthy nutrition targeting mothers of children 0 to 12 months with nutrition guidance from dietitians and community health aides, CHAs, because they actually work also in the community on a ground level and would have a better rapport than the nurse at the clinic. Secondly, the formation of support groups for parents/guardians of the children 5 years and under with a family history of a non-communicable disease such as diabetes type 2 or hypertension, and we would define this for the selection based on being a parent, having a parent with any of these diseases, or a sibling or aunt, uncle, cousin, or a grandparent. So I do believe that it's not only important for adults to keep in check how we eat, I would like to feed the children those little sweet snacks. They're so cute. Have a little candy here. but we need to take this in check. Thank you very much for listening.
Thank you very much, Ms. Brown. We look forward to seeing you back in a few years as Dr. Brown. So to wrap up this session, we're really happy to have Dr. Jacqueline Duncan, who I introduced before, so she's going to come to talk to us about rheumatic fever.
Good afternoon, everyone. Today I'm talking about a medical specialist, specifically a cardiologist in primary health care. So it's just a simple review of patients that we saw. And this was part of an initiative of the Ministry of Health and Wellness to strengthen primary care. My disclaimer, I'm not the cardiologist, but I'm presenting the findings. I was assigned as the internist to primary care. So rheumatic fever, as you may know, is a multisystem disease. It's caused by a bacteria called group A streptococci, usually a throat infection, typically occurs 2 to 3 weeks after infection. Not all people who have strep sore throats develop acute rheumatic fever. In fact, in outbreaks, up to 3% were shown to develop acute rheumatic fever, and of these, about 10% actually go on to have acute valvulitis. But interestingly, many people, in fact, most people with rheumatic heart disease don't even know that they've had a history or have never had a history of rheumatic fever. So they are detected when they come with complications of heart disease. So why are we talking about rheumatic fever? Well, it's still the main cause of cardiovascular disease in children under 10 in developing countries. In developed countries like the US, less than 2 per 100,000 school children have a history of rheumatic fever. And in fact, in some indigenous populations, such as in Australia, rheumatic fever incidence is as high as 300 per 100,000. In Jamaica, rheumatic fever is still endemic, and some describe it as a disease of economic disadvantage or of poverty. Now, we know that in terms of detection or diagnosis of rheumatic fever, it's a clinical diagnosis, and part of it is detecting carditis or inflammation of the heart. In clinically, what we call subclinical heart disease is actually more common in acute rheumatic fever than clinical heart disease, and you detect subclinical heart disease by echocardiograms. So it's very important that these patients have echocardiographic screening. We don't have much data on rheumatic fever in Jamaica recently, but we do know that in the 80s and in the 90s that among patients admitted for rheumatic fever, as much as 70% had carditis, and there was low adherence to monthly antibiotic prophylaxis. And this is important because antibiotic prophylaxis is important for preventing recurrence of rheumatic fever, as well as it's shown to slow the progression of rheumatic heart disease. And rheumatic heart disease is one of the most common causes for valvular surgeries in Jamaica. And you can imagine this is a problem where you have limited capacity to do cardiac surgeries in Jamaica and other developing countries. So we have a rheumatic fever program that was established in 1985, and its emphasis is on treating strep sore throats. And for persons who have had rheumatic fever, they should have monthly penicillin injections or some sort of antibiotic prophylaxis to prevent recurrence or to prevent rheumatic heart disease progression. The rheumatic fever register was also established, and this is a very important aspect of the program. So we basically looked at rheumatic fever patients in KSA. So the cardiologist would see patients that were referred to him by the public health nurse, referred from smaller clinics for persons who happen to come in for monthly prophylaxis. These persons would be seen by the cardiologist. And we just collected data on these persons. When they were diagnosed, did they have echocardiograms? Were they on antibiotic prophylaxis? Were they being followed up by the by any provider, whether it be a primary care provider, internist, or cardiologist. And the cardiologist would basically assist with management of these persons. We basically did a descriptive kind of thing. This wasn't an extremely robust study, but we thought it had good information for a public health program that we don't talk about much anymore. We looked at valvular heart disease versus no valvular heart disease, and that was self-reported or by echocardiogram results. So to start off, we saw 80 rheumatic fever patients, or 80 were reviewed by the cardiologist, which is less than 30% of those that were on the register. Most were women, in keeping with the pattern seen in primary care. Most were from health centers, and most of them were diagnosed on were hospitalized on initial diagnosis of rheumatic fever, 81%. What was interesting was that 1/3 of patients with rheumatic fever never had an echocardiogram. And as I explained before, that one of the criteria for diagnosing rheumatic fever is detecting carditis, which often is asymptomatic or subclinical and is diagnosed by doing echocardiogram. This is just a summary of what we found, and I will emphasize the things that were significantly different. Echo done previously, and there's an error in bracket for those with no valvular heart disease. That should be 33.3%, so that was significantly different compared to those that had valvular heart disease. Prophylaxis tended to be higher among those with valvular heart disease compared to those without valvular heart disease. And if you look at the last line, follow-up by a primary care doctor. So each rheumatic fever patient should have annual follow-up by a clinical clinician. But we found that persons, especially those with no valvular heart disease, at least 50% were coming to the clinic, regularly getting prophylaxis, but were not doing an annual follow-up. So as I said, it was a very simple review, but it highlighted some important things, that echocardiograms are available now, and that we're probably missing a lot of subclinical carditis in patients with acute rheumatic fever. And this has implications for duration of prophylaxis and progression of rheumatic heart disease, which I already showed you how important that is. And also we looked at antibiotic prophylaxis follow-up by a physician. We found that there were some persons that were on prolonged use of antibiotics and some who needed antibiotics that did not get their required antibiotics. This also highlights the importance of disease registers, because we have disease registers for diabetes, hypertension. We will be establishing registers for cervical cancer screening, that these are opportunities to do operational research. We have to look at the registers, the quality of care, how well they're being maintained, and whether we're complying with national guidelines. These all have implications for improving outcomes of these patients. Limitations, small study, subset of rheumatic fever patients. This is in KSA, generalizability to the entire island. We don't know if the rural areas are worse or better. The persons who kept appointments, so when the nurse systematically went through the register, most persons didn't come for the follow-up appointments with a cardiologist. I think we could have coordinated that mechanism better. There could have been misclassification as to who had valvular heart disease versus who didn't have, because we didn't have echocardiograms on everyone. And of course, we wanted to explore more issues about the rheumatic fever register. But certainly we see that this has important lessons, that medical specialists, in this case a cardiologist, can strengthen important public health programs in primary care, that disease registers have opportunities for strengthening research and quality of care, and that we have some low-hanging fruits for Jamaica's rheumatic fever program in terms of ensuring that all patients get echocardiography and screening for carditis, as well as to ensure that we use antibiotic prophylaxis appropriately. Thank you.
Thank you very much for very interesting and important talks. So now, is there anybody in the room who would like to ask any questions to either of these two speakers? Yes, ma'am, go ahead.
Thank you very much for your excellent presentations. I'll start with the last presenter, Dr. Duncan. Rheumatic fever. Now, I know about the streptococci. I'm a microbiologist. Now, when people have tooth decay, rotten tooth or something with their dental issue, there is the tendency for that to lead to rheumatic fever when streptococci is involved. Do you advise that those who have dental problems should, in quote, be allowed to do the echocardiogram?
Okay. Are you hearing me?
Yes.
Okay. All right, so the echocardiogram screening is once they're diagnosed with acute rheumatic fever. So if you don't have a diagnosis, it's not indicated. And it's interesting, I don't know the data for tooth decay, but rheumatic fever is more, it's associated with pharyngitis more than other streptococcal infections. So if you had a streptococcal skin infection or other sites, it typically doesn't lead to rheumatic fever. And it's interesting, they don't recommend echocardiographic screening in just to survey populations. So it's specifically if you have acute rheumatic fever, a diagnosis or suspected, and you want to rule out subclinical carditis.
Okay, thank you. Thank you on that one. Then the next one, the person that presented, yes, that is Ms. Brown?
Yes.
Okay, Ms. Brown, I'm going to look back at, yes. Early childhood body weight, yes. The life expectancy, you say is 3 point, what we would have gained would have been 3.6.
If our NCD risk was lower, we would have gained 3.6, but instead we only gained 2.8.
Okay. So, what is your recommendation? How can we turn that around?
Well, as I was saying before, is that most of the time, most of the care that we give right now is curative, we try to, persons, once they're diagnosed, and we have an intervention and the person gets a healthy eating. So it's starting from childhood. So the best thing to do is to advise mothers, especially mothers and grandmothers and aunts and uncles, that they don't give sweets to children, because at that sensitive period, Vygotsky speaks about a sensitive period in our lives where we developed a love or an affection for something. So that whole idea of having sweets actually starts from when we're really young. Our personalities are formed from when we're 3 years of age. Okay. So the best thing to do is to actually have households that are more at risk, like those that, this actual family history, actually have their eating come into being before they actually become diagnosed. So someone doesn't have to be tested borderline diabetes to actually be on a proper diet, and to ensure that the children, whether instead of having a piece of chocolate, will have a piece of ripe banana instead.
Okay, thank you. Now, what do we do with those young mothers, the teenage mothers?
Teenage mothers especially, and that's why the importance of support groups and the work of community health aides. Because for a lot of young mothers, just similarly to the study prior to me about screen time, it's easier to keep a child docile and calm by either putting them in front of the TV or giving them something that's soothing like a sweet taste. So it actually has to do with comprehensive parenting, but we're not taking on the whole of the elephant. We're just focusing right now on the nutrition.
Yes, I appreciate the nutrition and I appreciate your work. Thank you very much. And I believe that the parents are listening, because sometimes we have to target the parents,
Right,
the
the
teenage
parents.
mothers. And I took note of the person, the community aid worker who goes there will be more effective than waiting on those in the hospital. So I do appreciate that.
And I don't know if Professor Madden can give me just one more second, just anecdotal evidence outside of the study, that there are some young mothers who in the mornings give their children cheese tricks to eat.
Yes.
Right before breakfast, or some soda or something just to keep them calm.
I know it, I work in communities. I see them give them bag juice.
Right.
So I see that already in the morning. So we just have to target those groups as well. Thank you.
Thank you so much, yes.
Thank you so much. This has been another very good session. We have online. Okay, go ahead.
Yes, there's a question for Ms. Brown in the chat. So the question reads, were you able to identify any reason for that huge jump across the age groups from 3 to 11 months in 2020 compared to 1 to 5 years in 2021?
Well, yes, there is a possible reason, and it's postulated. In 2020, when the pandemic started, the Ministry of Health went on a healthy eating, comprehensive running of holistic healthcare campaign, and that impacted, if you notice for the findings for 2020, there was not a gender difference in being at risk for obesity or being obese in 2020. However, because they're getting older, the cohort moved from 3 to 11, and then they went on to 1 to 5. So that's a possible reason why is it that you've found that difference.
Are there any other online questions? No. All right.
Thank you.
Great. Well, we're just a little bit over time, and that's fine because it was all well spent. Thank you all for your attention. Please give another round of applause for our speakers. We wish them well. I believe we will be watching some stuff from our sponsors while we prepare for the next.
I have to stoop for the mic, no?
Along in the short of it.
Yes. But we just want to express our great appreciation. We know that you support us on an annual basis, and that you are a big proponent of research and excellence in research. And so we want to thank you for being willing to moderate this session. Thank you very much.
Thank you. Thank you very much. Thank you.
We were given a mandate to provide oversight of the redevelopment of the Conrad Regional Hospital. The oversight committee visited the site and inspected the building, and we all concluded that it was a worthwhile building to renovate. To construct a new building would cost 10 times as much of what we are spending to do the renovation.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. And the options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
we have not compromised on one service, one era of service that we are doing before the hospital was closed. We would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area. When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
The collapse of the Cornwall Regional Hospital posed a challenge to public health that I don't think we have seen post-independence. We engaged in a technical assessment to determine the value of what existed despite the challenges that were there, and it was determined that the building was sound. What we needed to do was to correct the air quality issues at the institution. You had to continue to use the building even with the challenges that you faced and the risks that were involved in that process of air quality issues, while transitioning and creating additional infrastructure around that main building to continue the services that were essential to saving lives. I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. Cornwall will one day become the best hospital in the West and probably one of the best in the Caribbean based on the work that is being done now.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them were identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility who have understood the nature of the inconveniences and why this is the case.
What will that moment of seeing that project to completion and walking into a new building feel like for you?
Well, you know, for me, it is likely to be, it will be a very fulfilling moment, without a doubt. I'll be extremely satisfied. It could be an emotional moment because we have seen the lows, we have seen the disappointments, we have seen the frustration, and to see now the success of a fully restored building will create joy and maybe even tears for some people. And for me personally, I will be elated, not just for me or for the ministry, but for the people who use the facility. doctors and the nurses who have put up with all the challenges over time, the patients who use the facility, who have understood the nature of the inconveniences and why this is the case. I look forward to that day, and I will celebrate on behalf of all who will benefit from the restoration, and indeed take those lessons. In fact, I've asked for a case write-up of the Cornwall experience, because I think the lessons to be learned should be transmitted to all across the public health system to avoid any other institution from having the same fate. So in a sense, Cornwall Regional Hospital should be a teaching moment for us. And that's one of the major objectives that I would have in terms of moving the process forward.
Hello, Jamaica. I'm Dion Jax-Miller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness.
Cornwall Regional Hospital was built in 1974. It was a gift of the Canadian government. They did all the technical work and provided the resources to build the facility.
Over the years, clearly, there was poor maintenance of the building, but also the building was modified by non-experts. People were constructing offices in the corridor. What that does is to interfere with the airflow and the ventilation. There was water seeping through the roof, it was leaking, but also seeping through the walls, and there were the plumbing fixtures and so on.
As long as you have moisture building up in concrete, in wood, and so on, you're going to have some conditions that are suitable for the growth of mold. To be able to find out the extent of that problem, basically the entire building had to be gutted.
The collapse of the Cornwall Regional Hospital posed a challenge to public health that I don't think we have seen post-independence.
Closing this hospital would not be an option. It would be like closing KPH.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. The options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
In 2017, when it was deemed that staff were primarily affected by the air quality issues, we realized that we had to relocate on a phase basis and not en bloc.
We are not on the main building, we are all across the campus. We are down the road, we are over West Jamaica Conference, and we are up at Falmouth. Movement on the campus means you have to, serving patient means you have to move up to Falmouth, you have to move down to Barnet Clinic, you have to move across the campus. And sometimes it is very hot, sometimes it's raining.
We have not compromised on one service, one era of service that we are doing before the hospital was closed. We would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them were identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
It was a worthwhile building to renovate. To construct a new building would cost 10 times as much. And when you're renovating a building, you get many surprises. And that is what has been happening at Cornwall Regional. So you demolish a wall only to find problems which were not planned for.
We understood that there are delays. We knew that persons were disgruntled. Some persons, of course, left. But some of us decided that we're going to have to stick through this and get through it.
When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
What I can assure members of the public is that we are doing all that is necessary in terms of identifying what are required, be it of resources, be it of management system and so on. And certainly these will be incorporated in our budget in going forward.
So we're building the capacity from now. We're looking to get all the expertise we need, that going forward, once the hospital is built, the whole issue of maintenance will not go back to where it was.
What will that moment of seeing that project to completion and walking into a new building feel like for you?
I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility, who have understood the nature of the inconveniences and why this is the case. You know, I look forward to that day, and I will celebrate on behalf of all who will benefit from the restoration, and indeed take those lessons, because I think the lessons to be learned should be transmitted to all across the public health system to avoid any other institution from having the same fate. So in a sense, Cornwall Regional Hospital should be a teaching moment for us. And that's one of the major objectives that I would have in terms of moving the process forward. Ladies and gentlemen, I wish to congratulate the Rotary Club of Downtown Kingston for hosting this webinar on World Diabetes Day. As we turn the spotlight on diabetes this November, we must acknowledge the scale of the problem of NCDs and redouble our efforts to solve it, drawing on all our resources, including our nurses, who are essential not only as healthcare providers, but also as professionals to whom we can rely for the promotion of self-care management among patients. Our nurses also play a role in helping to safeguard the mental health of their diabetic patients, from identifying emergent psychosocial to making the appropriate interventions to support their patients. This year's theme for World Diabetes Day, Diabetes Nurses Make a Difference, therefore is most appropriate. And in a year designated as the Year of the Nurse, this World Diabetes Day, we encourage stakeholders, from persons living with diabetes to their family and friends and others involved in their care management, to join our nurses in the effort to ensure the best possible health outcomes for persons with diabetes, and to, as far as possible, engage in behaviors to reduce the incidence of diabetes and other NCDs. Those behaviors include increased physical activity, a healthy diet, routine health checks, and strict medication adherence. All the best, and thank you.
Hello, I'm Dr. Shin Young-soo. I'm Regional Director for the Western Pacific World Health Organization. Today, on the World Health Day, I would like to ask you, how safe is your food? Does your country's food safety system protect you and your loved ones? Does it follow international best practice?
Harmful bacteria, viruses, parasites, and chemicals can contaminate food. Every year, millions of people in Asia and the Pacific are affected by diseases that are caused by unsafe food. Unsafe food causes more than 200 diseases, including acute diarrhea, cancer, kidney failure, brain disorders, and chronic malnutrition. Diarrhea is the most common symptom of food and waterborne illnesses, causing some 2 million deaths a year. The risk of unsafe food crossing borders is greater than ever. Trade in food and livestock products in Asia has increased.
Good afternoon, everyone. We've had a long day. We're on the home stretch. I am Renee Brooks, the Director of Standards Research and Development here at the Ministry of Health and Wellness. And it is my pleasure to introduce to you our guest presenter for this afternoon's workshop, the workshop in Ethics in Research. Our guest presenter is Dr. Princess Thomas Osborne, and she is a clinical pharmacist by profession who has served in the public health service for over 30 years. She joined the regulatory arm of the Ministry of Health in 1993 and served for 22 progressive years, the last 13 of which she served as the Director of the Standards and Regulations Division. In collaboration with the Pan American Health Organization, she laid the foundation for the establishment of the now fully functioning Caribbean Regulatory System, CRS, and has rejoined the Standards and Regulation Division, where she currently serves in the capacity of Regulatory Affairs Consultant. Please help me in welcoming Dr. Princess Thomas Osborne.
Good afternoon, everyone. Thank you, Mrs. Brooks, for that introduction. So we're going to go right into the presentation because I know that I'm running a little late. I have to try out to the pointer to see which way to go before Okay. So the objectives of the presentation, as Mrs. Brooks said to you, I'm talking about ethics, research ethics, but it's a little broader. So to provide a justification for the need for research ethics, many people really think we don't need research ethics, but we do. To explain the role of ethics committees and institutional review boards, I will refer to them as IRBs afterwards, in the conduct of research, outline the roles and functions of the Ministry of Health's Advisory Panel on Ethics and Medical Legal Affairs. I might just say the ethics panel afterwards. To share the review process of the Ministry of Health's Advisory Panel on Ethics and Medical Legal Affairs, including important timelines and deadlines, and of course to respond to any questions, which I know you won't have. So that one is. Okay, so what is ethics? Ethics really speaks about what is good or bad, guides people about what is good or bad. It's different from law because law is usually documented. If it's not written, it's not a law. But ethics tends to be abstract. It's not written. And it is a collection of fundamental concepts and principles of the ideal human behavior. So the principles help to inform how to act in a particular situation, but it also helps you to make choices. Is this way best? Is that way best? Which way should I go? And you make your choice. So there are codes of conduct agreed and adopted by the people. They set standards of how a person should live and interact with other people. And Dr. Obiora Eek, Executive Director of Global Ethics, said, ethics grounds in arguments on reason, unlike morals, for example. And this is how he defines ethics, but I will skip over it. So there are some broad ethical principles like honesty, trustworthiness, fairness, law-abiding, commitment to excellence, integrity, loyalty, concern for others, respect for others. And that respect is important when it comes to research ethics. So research ethics really applies the fundamental principles of ethics. Those are some of the principles we just went through when the researcher is planning, conducting, and going to publish research. And three of the fundamental, the gospel principles are respect for persons, beneficence, and justice. Now, there are other guiding principles: autonomy and respect. We said some of them: beneficence, non-maleficence, justice, and I've added scientific validity and honesty, because without scientific validity, the research really is no good, which makes it unethical. Sorry. So here I just sort of put a little body on the core principles we were talking about. For example, respect for persons and autonomy acknowledges the person's right to make choices, have their own views, takes action supported by their personal values, etc. And, well, I'll move on. Now there's a little activity. So we have persons online which I failed to acknowledge. I'm so sorry. How are you doing? I hope you're still remaining with us. This little activity here, I would like you to just place your thoughts on a piece of paper, or you could have them in your mind, thoughts that reflect respect. And then I'm going to go to the next slide, and you can compare what you had with what I had. So maybe I should ask Dr. Grant, what came to your mind when I said respect? I call you because I know you. Okay, all right. All right. Although I shouldn't have called you because you would have known. So here it is. Respect for persons. Each individual, we must realize that each individual is unique and each individual is free. So he's free to make choices whether or not those choices are going to be right or wrong. He has the right and the capacity to decide. He has value and dignity, and he has the right to informed consent in research ethics. That's very important. In terms of beneficence, the researchers, is it possible for me to take the mic out and stand closer to the... Thank you. To take it out and stand there. Is it going to affect the camera? Comfortable, yes. Thanks. So my screen is gone. It's not coming up. Okay, it's here. Oh, it has come back far. All right. Oops, it's at the bottom. Okay. So we then look at beneficence and yes, and I'm sorry. So the researchers must protect the physical and mental and social well-being of the subjects, reduce risks to a minimum or no risk at all, and retain the community perspective. Now, justification for research ethics. Often persons ask, especially students, why do I have to go through this? Why must I submit a proposal and wait for it to be approved and all of that? But I'm sure here we're all aware of some of the atrocities which have taken place in the name of good research in times past and probably still do, just that we don't know about it. And if you remember about the Nuremberg Code, it was established in 1947. There were about 10 articles, but the one on informed consent is a bedrock of that code, where during World War I, persons murdered and tortured people, and they said they were carrying out research. I remember seeing a woman do a presentation, and she said, they removed her uterus without using anesthetic. And I saw it about 40 years later, and she could still feel the pain. And there are other reports of violations which took place. So as I said before, the code relies on the principle of informed consent, insisting that the voluntary, competent, informed, and understanding consent of the research subject, that's a person participating in the research, is necessary, but it is on its own, it's not sufficient. It's not a sufficient prerequisite for lawful human experimentation. And in the United States, for example, there are laws which authorize carrying out research and which supports research ethics and so. We are not quite there yet, and I won't go into it, but you will remember the men, over 400 men, there were black men with syphilis, who were not treated even though penicillin had been introduced. And all of these things drove them to establishing ethics standards. So what is the role of I think I've skipped here. So the research ethics is necessary because it allows researchers to know what it is that is expected from them, but it also helps the subjects to know what they are to expect when they are participating in research. So it works both ways. And as regulators ourselves, it also helps us to know the areas that are necessary for regulation. And all research must conform to the established scientific standards, without which unsound research, as I said before, will lead to unethical research because risks are going to increase and persons might not get any benefits. It assures scientific rigor, generalization of the findings, universality, so wherever you go, the ethical principles would apply, objectivity. Now, in some places, like here in Jamaica, for example, resources might be limited. We might not have as much, for example, money to go around as richer countries. But that does not mean that the principles of research ethics should not be applied. It also encourages originality in research work. Now, the role of the institutional review boards, or as we have here, we have an advisory panel, we call it an ethics committee. They establish effective mechanisms for ethical oversight of human subjects in research. They review research protocols, and the protocols must really be quite stringent. they are independent, and that's what is good. So they can independently assure the safety, rights, and welfare of human subjects participating in the research, and they can assure that the persons are going to be adequately protected. They make sure of the appropriateness of the methodology that is being applied, and the adequacy of the informed consent. And that's a big thing for us. If we go through your research protocol might be perfect, but the informed consent is not at the standard it should be, then your protocol cannot be approved. And they can decide the levels of risk. The researcher might say, well, it is low risk. The IRB may say, well, we think that this is a high risk research, and so whatever criteria applies to high risk, that's what's going to be there. It prevents, having these bodies prevents exploitation of vulnerable groups, ensures favorable risk-benefit ratios so that the benefit and the risk there is a balance. The study should have social value, and you can have high social value. Or, for example, when we had the vaccination for COVID, that would be for high social value, or it may be low social value. And of course, I had said before, scientific validity and scientific value. So who now are vulnerable persons? And I got this from, I think the reference is there. There are minors, pregnant women, there are prisoners, persons with mental disabilities, persons who are illiterate, persons with limited access to health services, women in some settings, persons with limited education. We said that already. Sex workers have now become vulnerable, drug users. Now, these persons can still participate in research, but we must make sure that they sign the informed consent. We must make sure that they know all about the study they're going to participate in. They must know whether there are going to be any benefits to them. They must know whether there will be any risk to them. And they then must make the choice whether or not they want to participate. And they also should be told that if they choose not to participate or if they choose to stop, there will be no penalties to them. Now, in terms of the Ministry of Health, the medical legal panel, the roles and functions of that body would really be very similar to the functions I just described. So through the director, Mrs. Lewis Graham, my boss, who is sitting right here, a system for ethical review of protocols is maintained and proper records are also kept. So we can go back many years and we can tell you, well, someone had submitted this proposal before the study was done. You can't do it because it's actually unethical to repeat studies if there's going to be no value. Develops and updates tools for ensuring an effective review mechanism. So the tools include guidelines, various checklists for use in the process, terms of reference, which is still in draft, I think, but being developed nonetheless. And of course, they review the studies to be carried out. They approve and refuse protocols. Once a protocol is submitted, it's not automatic that it's going to be approved. So it's based on the outcome of stringent review. They adhere to the established terms of reference, assure protection and safety of all subjects in a study. They must also weigh the balance between benefits and risk, ensure and protect accuracy and integrity of scientific knowledge. And here we're talking about scientific validity and scientific value. So the study may be valid, but there is no value to it. Importantly, intellectual and property rights must be protected. And as said before, they must maintain fairness and valid. And this came from the terms of reference, even though it's in draft, so they can authorize the research to proceed without requiring amendment. They can require clarification, which we often do, or modification of parts of the research submission. They can defer consideration of the submission to a subsequent meeting if there is not substantial modification. So, for example, you turned it out, you asked for it to be modified, it came back, it still wasn't satisfactory. It can be deferred, or they can outrightly reject a submission. They can require or initiate another review of a proposal of a project previously approved by the advisory panel, and they may revoke approval if deemed necessary in circumstances where there have been relevant or material changes to the original proposal that was submitted. The panel has concerns about the conduct of the researchers or the research. So if there are serious concerns, probably it could be about safety. Let's say they are using a drug in the study, but they have not indicated what the side effects are likely to be. They have not indicated what the doses are that they're going to use. Then that can be turned back. Adverse events have been reported to this advisory panel. And if the protocol has been sitting in the ministry for more than a year, the applicant, who normally is a principal investigator, has done nothing about it, doesn't seem interested, they normally will write to that person and to say to them, well, we have this, are you still interested? Please respond within so many days. If you don't, then that now is put on hold. All right, so I think that we had gone through this already to ensure accuracy of scientific knowledge, was just adding a little meat to what was there before. Statistical significance is also important. However, the study might not be statistically important, but clinically important, and that is acceptable. Now, the Ministry of Health's panel is multidisciplinary, consisting of about 15 persons with a chairman who's named by the chief medical officer. The members serve 3-year terms, and these are renewable once the terms expire. They are all professionals from various fields on the panel, so it really is a very, I'd say, a scientific, a technically constructed panel. So in terms of the review process, the submission comes in, and there is an acknowledgement of receipt of the, no, I think I passed it, right. So upon receipt of a proposal, the responsible officer, and there is an officer who is assigned to this, carries out an initial review to see that all the requirements are included. A checklist of the initial findings is prepared, and the submission is given a unique tracking number. So whether it's there for a year or 5, that tracking number, you can find it using that number, and it is logged. If all the requirements are satisfied, then the submission along with the checklist is forwarded to a reviewer who is normally a member of the panel for no detailed review. The submissions really should be electronic and hard copy as well. Now, an acknowledgement of receipt along with the initial findings are sent to the applicant within about 7 to 10 working days. If the submission was incomplete, it is not passed to a reviewer. It is going to be sent back to the applicant with the outstanding requirements which the applicant is asked to complete and resubmit. And the time for resubmission really influences how long it's going to take for that, that protocol to be approved. Now, upon receipt of a protocol and checklist, the reviewer carries out a stringent ethical review and prepares an assessment report which comes to the panel for further review. And this report is accompanied by a recommendation from the reviewer. The reviewer may say, there were some simple issues. I'm recommending that it be approved based upon when they make the corrections or so. Or it might not be approved at all. The reviewer might recommend that it be sent back. The panel itself, upon looking, assessing what is before it, may also decide, well, we can't review this, it must go back, further clarification is needed, or it can be approved. Now, should panel members have concerns, as I said, the PI is asked to provide clarifications. If there are no concerns from the time of the initial submission to the notice of approval, then it is about 30 days. Normally, we take much longer than that, and really because it's rare that we get a submission that can go straight through. When we get a submission that is okay and can take that 30 days, we're usually so happy. Okay, so I'm through. So these are the references which are there, and it's time for questions.
Do we have any questions for Dr. Osborne? Hi, Dr. Alonge.
Thank
Yes,
you.
ma'am.
Yes. Thank you so much for that excellent presentation, very comprehensive. I was wondering, when you talk about the Tuskegee research and what happened at the time, the participants were not given treatment, even though the treatment was available. Now, I'm just thinking, in the time of the pandemic, there could have been other ways to look and take care of our population. And we never looked at that. What do you say about that?
What didn't we look at?
The other ways. There are other ways that we could have assessed other treatment at the time.
Okay, so, well, I will just say here that any response I give would not be binding on the Ministry of Health because it's going to be my own opinion. You know, there were many alternatives that persons came up with. They came up with a drink, a combination of herbs and so in tea that you could take. Many persons have still not been vaccinated. And, well, I had COVID, for example, and I recovered. I was not vaccinated. But I think that when you think about the number of persons who were dying at the time, it is not like when you look at the Tuskegee participants, they didn't even have access to informed consent. But syphilis wouldn't kill them overnight. There was time, it takes longer. When you're looking at the COVID pandemic, when it just started, people were just simply dying. I lost friends. I mean, very good friends, persons I didn't expect to die. They were here today, they were gone tomorrow. And I think that in the interest, and here is where the ethics come in now, because there is always this conflict. Because beneficence, and maleficence, you should do no harm. You should make sure that people are safe. But when you think about it, if you're going to perform surgery, if you're taking off, someone has diabetes and you have to do an amputation, by removing that leg, you're really causing harm. But in terms of the harm that you cause, what is greater? The benefit of removing the leg so that the person lives longer, lives a better quality of life, or not take off the leg and that person dies probably within a few weeks, within a few months or so. So in the same way in the pandemic, I think the government had to make a decision. Do we look at alternatives? This thing is so new. We don't know what a workable alternative is. Do we take time to look at alternatives, or do we allow them to become vaccinated until an alternative is found? That is what I would say.
Thank you.
Thank you. Very informative presentation. Well, a quick question. If the ethics turns down a proposal, say you have said no, can't go, and can the individual ask for review? In the sense that, can they come and say, well, we really don't think this should be turned down? Can we?
Yes, there is a process of appeal, and I will tell you that the committee never turns down an approval unless they've really looked at it. For example, what if it's a clinical trial? They want to use a drug that is not known to us. It has not been used before. And I don't want to use the word guinea pig, but in our language. And or people now would be guinea pigs, so to speak. Now, we really don't know what to expect from this drug. They really can't tell us much either because it's a drug under investigation. If we are not satisfied that they can say to us, this is what we have in place, in case a subject becomes ill, that subject can be quickly taken to hospital. We know what is causing the illness and we can treat appropriately. If they can't satisfy us that their interventions are going to be to the benefit of the participants, then we are not going to say yes, go ahead with it. But there are times when we have turned the proposals down. They have gone back, they have rewritten, they have done more research, etc. They have resubmitted and they have been approved.
Thank you.
Thanks for that presentation, Dr. Osborne. Good to see you. Wonderful. One of the questions oftentimes posed, or an uncertainty faced by researchers, is to determine whether their research activity will indeed require ethical approval. What are some of just the basic general guidelines that you would give to researchers to help them to determine whether they need to come to that board for approval? Thank you.
So we face that all the time. And I just want to say that Mrs. Louise Graham is here. And I would want to invite her to come up here because she's a boss. She can answer. Or if you think that, you need to say something. Really, well, we have said that research which is limited to an institution, like a hospital, if it's going to be done in the hospital, for example, I've went to a hospital and saw them. My own brother was in hospital. He had been in an accident and they were using papaya, green papaya, to dress the wound. In a way, they were carrying out a research because the studies were not done. But they didn't have to come to the ministry to have that approved. When you think of the risk, what would be the risk of using the green papaya? He was still getting antibiotics, etc. So it was a local dressing that was applied. On the other hand, if you're talking about a clinical, you're going to have an intervention that is going to really is going to require approval. And it's been a little challenging for us because we've said to the institutions, you don't have to send everything to us. But sometimes themselves are not sure whether it should come. So we usually say the best thing to do is to send it. If it does not require approval from our ethics panel, we will tell you that you really don't need our approval for this. You can go ahead with it. But it's best to come. We've seen persons come to us after they have started, and I should have said this, that our panel will not approve a study that you started, you're well on your way with it, and when you meet a snag, like you have to get approval from another ethics body, and they tell you, well, you should have gone to the Ministry of Health, you then come to us for approval. It really doesn't work that way. So if you're not sure, you can come. But I think Mrs. Louise Graham could, or you don't want to say. Yeah, but usually if you're not sure, For example, students. Students do a lot of research proposals that are not in any way invasive or so, but we find that often some ethical issues come up. Sometimes it's the kind of questions that they want to ask people, and you now have to make sure that they can tell you how they are going to provide confidentiality, or they're going to keep people's information private and all of that. So if you're not sure, you come.
So there is a question in the chat. Is there any consideration for expedited review of research ethics applications when research is urgent and important, such as during COVID-19?
And in fact, there was a slide on it which said expedited review. I think I skipped in doing the thing, a couple of slides. Yes, we do an expedited review, especially if the research is funded and you have a deadline, your sponsor has given you a deadline and so on. We do expeditious review. And also, if it's a very simple research and it does not require going over and over again, you know, and no ethical issues are jumping out at you, it can be expedited. So presently, we do expedited reviews. But usually when you're talking about clinical trials, it's unlikely that it's going to be expedited. And you can well understand why. And especially for students, because they usually are coming so late. When they have these deadlines to meet, many of them are funded, but they have a deadline because you're talking about graduation and all of that. If we can expedite it for them, we will. So thank you very much. I think that's it.
Thank you, Dr. Osborne. No, man, you can return to your seat. Thank you. Oh, no, Dr. Osborne, we have a gift for you. A small token.
It's not expected. It's so nice. Come along, Miss Grant. I love getting gifts.
Dr. Osborne, we want to thank you so much for being willing to take on this presentation. I thought that it was excellent. It gave a lot of important information regarding the ethical review process. And so we just want to thank you for taking the time, and we want to grant this to you as a small token of our appreciation. So thank you very much.
Thanks.
And we also would ask Mrs. Brooks, who is hiding, but to also come forward. And so I'll speak while Mrs. Mullins grants. But Mrs. Brooks, we want to thank you so much for being willing to moderate this session. You are part of us. So sometimes you might say familiarity breeds contempt, but she is a part of our Secretariat, and we do appreciate her continued input and the enthusiasm that she brings with respect to the Health Research Conference planning. So thanks again for being willing, and we do appreciate this. Thanks. And so this is the end of our first day of presentation. And we just want to thank all participants who have journeyed with us and have stayed with us for the entire day. We really had a wonderful time of rich presentations, and we can reflect on what the minister had said this morning with respect to moving research forward. And so all of the policy implications that have come out of today's presentation, we will strive to see that the findings will be showcased in other media. We have another wonderful day tomorrow, but I would encourage our participants online, please remember that we start earlier tomorrow. We start at 8 a.m., so that might be a bit early for some persons, and we have a full day of research tomorrow. So once again, we just want to thank everyone, and we close this day's event, and we look forward to coming back at 8 a.m. tomorrow. Thank you.